She could have, I even said, hey, if you can't make it, Congresswoman, I understand. I know birthdays are super important, but she said, no, I do my job. I'll be here. I'm going to be here and I'll do good. And she's here and she's doing good work. I am not a singer at all, so I won't sing. But I just want to make sure that we all wish Congresswoman Kelly a happy birthday. So on the count of three, we'll just say happy birthday. So 1, 2, 3. Happy birthday.
He didn't want me to kill him. Good morning, everyone. So good to see you. Welcome to day 2 of this year's National Minority Equality Forum Leadership Summit on Health Disparities and Brain Trust. We heard so many wonderful insights yesterday from leaders, experts, physicians, and many other professionals who are moving the cause of health equity forward. So thank you to all of you who presented. I was in 3 of the panels, and you guys were fabulous. As chair of the Congressional Black Caucus Health Brain Trust, I rely on conversations like the ones we are having this week to inspire and amplify my work in Congress, and I'll talk to my other colleagues about it also. It wasn't long ago that health equity was mostly an afterthought when members of Congress were crafting policy. I'm so proud of all the progress that's been made, especially with all the support of my colleagues and me in the Congressional Black Caucus. It has consistently been the CBC who has said no dice to draconian cuts to health programs that support low-income, rural, and underserved communities. We've made sure that equity and bias training are incorporated into legislation that addresses maternal mortality, clinical trials, cancer treatment, and so much more. So never doubt that representation really does matter and that your voice can make a difference. You have the opportunity to lead our political leaders and our medical professionals by example. I know just how much work you do to ensure that people around the country have access to the quality healthcare they deserve. And even the work that I do has been informed by you. I look forward to joining you for today's events and sharing more about my work in Congress to address health disparities, specifically addressing the rising maternal mortality rate, increasing telehealth services, diversifying clinical trials, and the healthcare workforce. And in addition, we still have a lot of work to do around gun violence prevention, which I think is a public health crisis. So thank you so much for your hard work. I look forward to learning more from you long after we leave this evening. And with that, I'd like to introduce the man of the hour. Let's give him a round of applause. 25 years, Dr. Gary Puckett.
Morning. So this morning, I'm going to break tradition for just a little bit here. And when I say that, I want to produce a couple of slides for you. I never do slides, but this morning I'm going to do that. And the reason why I'm going to do it, because of the title of our summit. Now that we have the data, what are we going to do about it? And I also want to pick up on some of the themes from the conversation at the town hall that we had last night. So if I can get them to, so this is all about the demographic shift, right? This is the objective reality that is driving American public policy. And so as you can see from the slides, right, that what's happened from 1960 going to 1950 is that there's an emerging majority, a new population that is beginning to change American healthcare. Next slide. And so for our folks, and I just took the drug data, but we could talk about devices, we could talk about healthcare. And here's the point, right? If you are doing a clinical trial today, right? If you're starting a clinical trial today, I'm saying this to all of my pharma friends and others are doing devices. The people that are going to use your product by the time it comes out of the clinical trial are diverse populations. So when we got started at NMQF, when we talked about clinical trials, it was like a nice to have, right? But it's not a nice to have anymore. This is the America that we are now confronting. And so I was at a meeting in Europe with some Eastern Europeans and African countries, and they were talking about themselves as an emerging market. And I said to them, America has an emerging market, and they broke out laughing because they think we are a mature marketplace. We are not. We are not. The people who are coming into the majority, they don't have access to all of those innovative therapies. That's what the fight is about. We need to get them access. And so that's when we have the data. Now what are we going to do about it? And that's part of the point I want to make. Next slide. And so just take a look, keep advancing the slides. What you're going to see state by state: California, Texas, Arizona, New Mexico, Florida, Maryland, New Jersey. They're all becoming minority states, right? That's why we're confident about what we're doing, because we are looking into the future and we see it. We see the future, and we're saying that if you are in healthcare, that's your market. That's what's emerging. And it's interesting. I have these conversations all the time with executives in healthcare, and they don't get it. Even when you show them the data, they don't get it. They're so blind to it. But this is the objective reality, right? This is why last night there was such confidence about the reality of where we're going and what this conversation. Now, I'm not going to suggest it ain't going to be a big fight, right? Because we have to change the legacy healthcare system, because it's rationed healthcare to those communities forever. And now we're saying that we have to provide really frontline innovative therapies to them. Next slide. I just want to point out that the majority of minorities are getting their healthcare through Medicare and Medicaid. Medicare and Medicaid. And so they're an important part of the fight, and not to leave the commercial folks out. But we have to fix Medicare and Medicaid in order to make sure that our communities are getting access to best modern therapy. Next slide. This is my final slide. I love this one, right? Americans live in about 38,000 zip codes. 70% of African Americans live in 2,500 zip codes. 70% of Hispanics are in 2,500 zip codes. 79% of Asians are in 2,500 zip codes. Very targeted. So when we're talking about inequities in healthcare, we know the zip codes where we gotta go is the point. So you've got this changing marketplace, you know where you gotta go, and you have to get on the ground in order to build those sorts of change. We have the data, now we need to know what to do about it. And so we say to our partners, we want to take you into those communities, and we have to restructure the way in which we think and deliver about healthcare to them. So I've broken the norm here because I wanted to make sure that you understood the data and why we speak with such confidence about the future, because that is the future. So when people say we don't want D&I, they're nuts, right? Because that's the workforce. I mean, what are you going to do? I don't even begin to understand what the Supreme Court and those folks think about, because they're living in the 20th century. They're not living in the 21st century. America has changed dramatically. Demographics are destiny. So what I want to do now, I'm really proud of my team at NMQF. And I want to take a moment to introduce, they're not all here, but introduce some of them to you, because I get a chance to sit up here and run my mouth, but they actually do the work, right? And so I always want to acknowledge the folks who do the work. So I'm going to start with Kenesha Adams. Kenesha, she is the person that controls my calendar in my life. And I know I call up Kenesha and say, what am I supposed to do? Where am I supposed to be? Brandon Garrett's my chief of staff. He tells me what to do. He keeps me on time. Ashley Hill works for Brandon. Ashley. Oh, they're okay. Sorry. Dilip DLIP is our AI. We are going AI. So what you probably don't know is we built our own private cloud, and DLIP is driving our work in AI. Michael DeSalvo Solarte, he works in our health information services. Walter Brown, Walter here. Don't see Walter. Walter's out, chief exchequer. He keeps the money. Shante Hartsford. Shante works with our clinical research group. Jennifer Matisse. I'm sorry, Shantia. Jennifer Matisse, she's one of our NPHs. We got a whole bunch of NPHs. We believe in running numbers. And she's, and just got a doctorate. I'm sorry, doctor. Catherine Shavaz. Catherine has just come aboard. She's part of our grants operation. Love to have her doing fabulous stuff. Michaela Kudre. Michaela's another one of our NPHs. She's been publishing papers. Another doctor. I'm sorry, doctor. She's been publishing really fabulous papers all over the place. We've been doing work in COVID, and we've got a 5-year study, and she's one of the lead authors on a bunch of papers that we are doing. Sharonda Du Bois, interns. We love interns. Is she here? Let's see. Okay. Charlie Fromm is another intern, helped us work on the White House paper. We did a paper for the, here comes Charlie. Come on, Charlie. He worked on the White House report that is really driving the work that we're doing in cancer. He did fabulous work on that. Dane White. Oh, there you go. Dane handles internal communications. We need to talk to each other, and he does that. Leslie Ravaz works on our faith-based and clinical research, et cetera. Cecilia Masters now. Cecilia is driving it. She's our grants manager and financial manager. She is fabulous. I'm just telling you. She does, really. Keiko Purnell. Keiko's been with us for a while. She's been working on our public policy, a lawyer. Love to have Salvador Alisi runs our clinical and social research group. We're doing clinical double doctor. I'm sorry, double doctor. He's running our clinic. We do clinical trials. We do research. We go into communities and we actually study folks, and his team sort of drives that. Akia Blue. Akia is coming to take over the presidency of SHC. She's fabulous, absolutely. Christina Edwards. Christina works for Salvo, clinical trials director, manages a lot of our clinical trials. Derek Fournier, another NPH doctor. I'm sorry. We got a whole bunch of doctors, right? That's what we do. We got a whole bunch of doctors. Brenda Henderson. Brenda here? Okay. Marilyn Pumphrey. So when we go into communities, we do events, we do listening sessions. We want to understand what's happening at the community level. Leo Zhu, Dr. Leo Zhu, I'm sorry. Leo, I think you've been with us for what, 20 years? Getting on 20 years. Long list of papers across therapeutic areas that she has published and led she's a statistician and led a lot of our research work, and she's just absolutely fabulous. I just call up and say, we need some numbers, and she generates them with the team. Adjua Carmentine, she's our director of communications. She's going to be going on maternity leave soon. Twins. Okay. Kayla Emerug, he runs our health information services. So we sit on top of 5 billion patient records. We collect data on 160 million lives a year, covering over 100,000 different conditions, and Kayla leads that group. Matt McCurry. Matt has been a great partner. Obviously, Congressman Kelly's Chief of Staff, works on the 40 Under 40 project with us. He's just been absolutely fabulous. And then we have a scientific advisory board. Donnie John, Donnie, where are you? Come on, Donnie, come on up here. And Carmen Matthews works on that as well. Cameron Matthews here. Cameron, yeah, come. So this isn't all of NMQF, but this is a good part of the heart of NMQF. And so when I say to you, I don't do anything, I'm being really, really honest with you. I don't do anything. I just get up here and make a lot of noise, but I'm incredibly proud of this team. We are about the business of transforming American healthcare. We are very intentional about that. We think that the future of American healthcare is in those communities that have been left behind. And we have lots of programs. And I'm just going to end with this because it is always on my mind. We've been working with the White House on the cancer moonshot. The president said that he wanted to reduce cancer mortalities by 50% over the next 25 years. I'm kind of old school, and if the president said we should be working on something, I think we should be working on something. And so we've been going into Flint, Michigan, Houston, Texas, St. Mary's and St. James Parish in Louisiana. We're about to put some sites in North Carolina. And what we're trying to do is bring the cancer moonshot into communities and lower their mortality rate through clinical trials, patient engagement, advocacy, because in those communities, what we found is two things. They're being exposed to carcinogens and pollutants through no fault of their own by public policy. And public policy has also not provided them access to best modern care. And what we're trying to demonstrate are really two things. One, we got the science and the technology to actually change their life experience. And number two, we can pay for it. We can pay for it. We cannot give ourselves permission to put people's lives at risk because we say we don't want to pay for it. That's not on. That's what the fight is about. And this is my team that's working together to drive that agenda. And I want to please thank you for and welcome. I'm sorry, what? Oh, in the center, oh, Jesus.
From cell therapy to robotic surgery, we're leading the way in healthcare, harnessing our strength in both medtech and innovative medicine to drive progress across the full spectrum of healthcare solutions. We're building a world where complex diseases are prevented, treated, and cured, and where solutions are personal. Every day, we profoundly impact health for humanity. We are Johnson & Johnson.
Do you live in that area? I live in the Boston area. How about you? In New York City. Okay.
So we're starting. When's the clock? Oh, sorry. Hello, good morning, everyone. My name is Christina Edwards. Welcome to today's first session titled Bridging Gaps with BITS, Enhancing Clinical Trial Inclusivity Through Digital Connectivity. Again, my name is Christina Edwards. I work as the Director of Clinical Trials at the National Minority Quality Forum and also lead on specifically our clinical trial diversity initiative with the Alliance for Representative Clinical Trials and our My Clinical Research Network. So with today's panel, we have a few esteemed panelists that we're going to get to meet in a second, but I want to kind of give you all a little bit of background information on what we're going to be focusing on today. So again, clinical trial diversity, but we also like to say clinical trial inclusivity, and we want to focus on that today and take a look at how has that been enhanced, but specifically through data and through artificial intelligence. You know, how has that advanced clinical trial onboarding, clinical trial patient recruitment, just the whole life cycle of the clinical trial? Has it improved representation in clinical trials as it relates to diversity? And we're going to get to hear the perspectives of our panelists today. And I want to go ahead and begin introducing them. To my left, we have Sri Ramaswamy, the VP of Commercial Communication at GSK. Then we have Sid Jain, VP of Global Development, Data Science, and Digital Health at Johnson & Johnson. Next, we have Rose Wang, the founder and CEO of 1104 Health. Then we have Chet Robinson, Chief Medical Officer at Jasper. Can we give them a quick round of applause? So I'm going to go ahead and let them tell them a little bit about themselves, their organizations, and the work they're currently doing in clinical trial diversity. So we'll start with Sri.
Thank you. I think we need more energy in the room, right? I'm Sri Ramaswamy. I'm delighted to be here. I'm VP of Commercial Communications at GSK. I just want to give a big shout out to my team that's here with us at GSK, who have done some amazing work and continue to do a lot of amazing work to sort of bridge the gap in inequity. And I will say that at GSK, we've been working very hard on this, not just on the clinical trial side, but also with our medicines and our vaccines. The one thing I will say is that we're reaching deep into the communities. We're leveraging data to develop, innovative projects, because this is such a critical thing, and we can't do this on our own. We've got to solve this together for humanity. And I will say that, one of the things that is really important in the context of this conversation is not just about, diversity. It's the inclusion part that is so critical. You all know, and wherever you work, that you can have a diverse workforce, but if you don't have an inclusive workforce, you're not going to get to the intended objective of what you're trying to solve for. So I would say clinical trial diversity includes inclusion and making sure that you're bringing people along so that we can have a better outcome for humanity.
That's great. Hello, everyone. Thank you, NMQF, for inviting me here. Thanks to the fellow panelists and everybody who's doing some amazing work. So you gave a shout out to GSK team, same for the J&J team, but everyone who is in this room, I know is doing some amazing work to bridge the gap in clinical trial inclusivity. And I'm privileged to serve as the head of global development, data science, and digital health at J&J. We're really truly harnessing the power of data and digital health to transform drug development. And J&J is uniquely positioned to really lead the innovation, both from medicines and medical devices. You just saw something about we're developing both the cell therapy, but we're also innovating how robotic surgery is done. And there's tremendous opportunity to use the infusion of data from EHRs or labs or images to harness and make sure we're making our research inclusive. Being a data guy, but I also like to talk about my own personal journey as someone with a chronic disease for over 20 years. To me, it's really important because I'm a member of the Asian American community. And when I go to a doctor's office to talk about my disease and the treatment options, generally the answer is, well, we don't know. I mean, generally the data is that this would work, but we don't know for sure because we haven't had enough research done on this particular community. And we have to bridge that gap. And we have a number of examples we'll talk through. And here at J&J, we're really focusing on problems that have the biggest impact on solving for healthcare and patients. So looking forward to this panel. You know, AI and technology and the use of it is not new. We were doing this well before generative AI became popular. It's really how do we leverage the expansion and the explosion of the technology to continue to expand that progress. So looking forward to this.
Thank you, Christina, and thank you. Great to meet all of you, and it's wonderful to be here. My name is Rose Wang. I'm the founder and CEO of 1104 Health. I was trained as a computer scientist and had been a serial technology entrepreneur. I got into healthcare and clinical research because of a personal tragedy. That's my personal journey. I lost my husband to metastatic cancer 5 years ago. And after his death, a lot of mourning, I really looked into the journey we had. And that's why 2 years ago, I founded 1104 Health. One of the key learnings I got from that was because he was diagnosed as an advanced stage cancer patient, we should have known, but we weren't because we were cancer illiterates, that for cancer patients, clinical trials should really be treatment options from day one. And further exploring the problems, and it's like blind man and elephant. We were feeling around the entire quote unquote system, which really felt non-systematic to us at all as caregivers, as cancer patients. And I think that's a journey for just about everyone. Even if you are a doctor, I have one of my best friends is a cardiologist, and she said the same thing. Somebody in her family had cancer, and it's that whole cancer ecosystem is very non-systematic and sub-optimized in pockets, in ecosystems, in geography. So what the work we're doing is bringing that to light. Our mission is to improve access to cancer clinical trials in the community because 85% of cancer patients are treated in the community. And our community providers, we trust our community providers. We have relationships with them, and we need awareness, and we need access, and the providers need more access. They need to be increased. Their access to research need to be increased. So all of that, I say, is the work that NMQF is doing is great to bring that to light, to see the concentration of zip codes where our minority, medically underserved populations are. And even for people who are not medically underserved, we have a healthcare inequality issue. So that's why I'm here.
Thank you.
Great.
Chet?
Thank you, Rose. My name is Chet Robinson. I'm the Chief Medical Officer for Jasper Health. It's such an honor to be here. The field of Jasper is a company that does digital and telemedicine cancer support and navigation. And the whole area of cancer support and navigation actually is similar, many synchronicities with NMFQ. So in about 1989, 1990, Dr. Harold Freeman in Harlem was realizing that many of his patients were not getting good cancer care. And so he was one of the very first people to found cancer navigation. And of course, what they found was at that time, those of you who are my age remember we were fighting the war on poverty. And they found that poverty was actually an independent risk factor for cancer, and that by having navigators within the community really helped to impact the care and the outcomes of those patients. As they began to continue to do that, by 1999, 25 years ago, similar to what we're celebrating here, NCCN had so much data showing the improvement in clinical outcomes. There were better 5-year survivals. There was better quality of life. There was a big difference in financial outcomes. The cost of care was much lower in patients receiving navigation. The NCCN established guidelines, the same kinds of guidelines that they use for treatment of pancreatic cancer, for the treatment of all cancers in our country that determine risk, diagnosis, treatment. It was so important about cancer navigation that they formed guidelines and made that part of that whole fabric of being able to do that. So when we look at 25 years of data, part of that is looking at the data that's been created from that. Today, there's about 18 to 19 million people, similar to Rose's family, that have a history of cancer, that still live with cancer, even though they might not be actively diagnosed, they still deal with it in some way. There will be about 1.8 million people that will be diagnosed this year with new cancer. Right? Of those people, the studies show that between about 20 to 61% of those people will have significant psychosocial distress. They will be having to deal with the personal consequences of the cancer. We have phenomenal treatments for cancer. We have phenomenal research and drugs and genetics that help us to be able to medically manage it. But if the person or their family cannot be involved in those treatments, it's all for naught. Distress management, psychosocial management, navigation and support is central to be able to have strong outcomes, right? So when we begin to think about clinical research, one of the things that happens with cancer is that you begin to feel like you are powerless. All of a sudden things start happening to you. You don't necessarily know what they are, but you know you need to do them. And one of the challenges that almost everyone goes through is, what can I do about this? Well, there's some things you can do as far as nutrition, as far as exercise, as far as getting educated about what might be coming next, what the options are. But the other thing that, in fact, Sri and I talked about this earlier, is that the involvement in clinical trials many times comes down to trust, right? But when you have a navigator that you've established this level of trust with, it gives the opportunity to educate. It gives the opportunity to identify clinical trials. It gives the opportunity to be able to support that person as they go through the clinical trial. The other thing that it does is, because what you're helping the person with is kind of the helplessness of cancer, is it gives the opportunity to change the paradigm, to help the people to begin to think of themselves, right, as been mentioned, that those people are now warriors against cancer. This is something they can do. This is something that they can take control of and be involved in that clinical trial, so that regardless of what their gender or their race is, that they are helping to create the evidence that's needed to be able to treat, right? It completely turns that by building on a trusted relationship to help to educate and empower people to be involved in that. So very excited to be here. Very much the 25 years of evidence and seeing that all come together. And as Gary mentioned, this is the time. And we'll talk a little bit more about that in a few minutes, but thank you for this opportunity.
Thank you. So we want to bring it back to Sri. We want to do some level setting. Diversity has been a hot button. Clinical trial diversity has been talked about more frequently in recent years. We have FDA mandates that have come through. So Sri, I want me to talk about, at GSK, and in your opinion, why does diversity matter in clinical trials? Why is it important to get diverse patients enrolled in clinical trials?
Sure. So diversity in clinical trials and inclusion of a diverse group of patients in clinical trials matters immensely. Every data point comes from a person. And the more data points you have, the more informed you can be about how a medicine works or doesn't work for that matter. I can tell you years ago, I worked for a company that made a wonderful medicine, at least I thought it was wonderful, for hypertension. But there was only one problem with the medicine. It worked really well in the white population, didn't work so well, didn't work at all, frankly, in the African American population. And when you begin to peel the onion, you realize that the reason for that is because many of the clinical trials that were conducted for this medicine were done in Scandinavian countries, which did not have diverse populations. So it's really, really important to ensure that you address that. And to the point that you made earlier, Christina, the US government passed legislation in 2022, right, requiring drug developers to devise clinical trial diversity plans for medicines under investigation. So that's one part of it in terms of, why diversity matters and why it's hugely important. We also know that different medicines, vaccines, can affect people differently depending on their ethnicity, their sex, and their age. And it's a fundamental step to understand that to build health equity. The other thing I mentioned earlier, and I want to belabor the point because it is important, and I want to underscore it, is that inclusion and diversity is also key, right? You can't just do it and say, we've got a diverse population, you've got to include people. And this is where it gets important, because when you're including people, you have to think of all of society, not just people in major metropolitan areas or people who have access to the best academic institutions in cities or have transportation to get there, who can afford to park, who have good internet at home. These are very, very different things, right, for different populations. And so it's really important to understand that if you want to do this right, you have to include people, maybe go into the communities where they are, meet them where they are, help them where they are, empower them where they are, and also ensure that they are being followed up on. So that's another point. Finally, an important thing that I want to say is that when you think about clinical trials, a good example of it is women. They were the original underserved, underrepresented populations in the realm of clinical trials. Why? On paper, it may seem logical to exclude women because if one is pregnant, for example, it may harm the child. Except that women were still being prescribed medicine that was not tested on them. So instead of protecting women from clinical trials, we should be protecting women with clinical trials. And that should be the same sentiment for all underserved populations. So that's an important reason why diversity matters. I think, Christina, if you think about some of the challenges in terms of enrolling participants, and again, going back to my friend Chet here and the passion we share for this, we're having the same conversation today that we had last year, that we had the year before last, that we had 40 years ago. And that is because trust or lack of trust is a major issue. I don't have to tell you about it. Look at Tuskegee, right? And look what happened as a result of that in terms of the reticence in the African American community to trust people or trust the government or trust clinical trials, right? And so what's really important is to ensure that we think very deeply about why is it that the same messages are not landing as effectively on different populations to really raise the bar on this. Because otherwise, it's going to sound like a Shawshank Redemption moment, right? Constantly denied. And we have to really get better at really understanding what it is that's driving people to, what can we do more to have people trust the system more, trust the processes more. And that can only come from the community. It can come from empowering people who, we often say, you can't be what you can't see. It has to be something that you can identify with. The other thing is making sure, for example, that you have decentralized clinical trials where you take people to centers that are outside cities, not by the academic institutions, for example, making sure transportation is provided in certain cases. These are just some of the negative social determinants of health, for example, that need to be addressed. But I think it's really, really important that we look at those factors in order to even the playing field. And I'll just say, one other quick thing before, which is there was a JAMA, the Journal of American Medical Association analysis of FDA data between 2014 and 2018, where some 84% of women in oncology trials were white and only 2% were Black, right? Even though Black women are 41% more likely to die from breast cancer. We've got to change the narrative, guys. We've got to be better at what we're doing.
Thank you. So I'll take it to Shet. Kind of piggybacking off what Sri mentioned and the required support that is needed to ensure clinical trial inclusivity as it relates to the oncology space. How important is it for navigation to be implemented in some way to get them through the life cycle of the clinical trial?
Yeah, thank you for that question. And Sri, thank you for teeing up, because 100% agree how important it is. But how do we do that? How do we establish trust? How do we turn that? And I think the exciting thing, and one of the things that we're approaching at Jasper, is that much of cancer care now is provided in centers of excellence or in regional areas, right? And so when the person leaves that care, right, they're a little bit on their own. Yes, somebody will help them maybe to set up appointments, right? And it becomes challenging. So going into a community is very challenging. Plus, people tend to sometimes be much more mobile. Families are not always where the person is. It's a much more complex challenge than what it used to be. So how do we address that? So what we've done at Jasper is to put together a telemedicine platform so that we can connect with the patient wherever they are through telemedicine, through telephone, through a digital app. And one of the things that we find with the digital app is that it allows people to communicate directly with us any time of the day or night. Because quite often the symptoms that you have are not during business hours. They're at 2 a.m. when you start getting afraid of the appointment the next day, right? And then from that relationship of being able to connect all the time, being able to connect in whatever way you want to, whether it's through telemedicine, through telephone, through app, through any of those kinds of ways, there's this relationship that's established. So we put together, one of the things that's challenging about clinical trials is there's a lot of them, right? And it's difficult to know which one to be involved in. It's difficult to know how to get involved in it. And unless your doctor says you should consider this, it's really difficult to know. So what we've done is put together what we call augmented intelligence that queries all of the clinical trials. And for this one particular person that we're working with, we can say, there's these 2 or 3 trials that you would perhaps be qualified for, right? And this is what it's about. And this is how you could have an impact on that information, right? If they're interested, then we can help them to get enrolled, contact them with the PIs or whoever is doing that. And then once they're enrolled, then we can help to support them as they're going through that clinical trial, right? So it's the connection of that community to help identify, to help educate, to help support all the way through the clinical trial. So cancer care and navigation is not just from the point of diagnosis. It goes through treatment, it goes through clinical trial, it goes into survivorship. The other thing that's helped with this is that starting this year, CMS approved reimbursement codes for all of this. So now we can be reimbursed for providing all of these services. So the patient has a very little to no financial burden, right? It's not costing the health system money to provide this, right? There are Medicare, Medicaid funds to be able to help to do all of this, right? So, when Dr. Puckrin talked about, now is the time. Now is the time because all of the information we have about how to do this, we now have both the technology, we have the reimbursement, we have the way to connect people to move this forward, to get people involved in clinical trials, to give them power, right? And equally as important, to give these incredible people that are developing drugs and devices the information they need to be able to do that so much more specifically. I think care and navigation can be really central to be able to help move this whole clinical trial effort forward.
Absolutely. To Rose, similarly with I mentioned Alliance for Representative Clinical Trials, and our focus is working with community clinicians and getting them engaged in clinical trials. I want to get your perspective on 1104 Health's ideas on the role that research sites play in encouraging community physicians to speak to their patients about enrolling in clinical trials.
So I will share some data points first and paint the picture for community providers, oncology in specific. In between 2016 and 2021, 5 years, there have been 207 approved oncology drugs from FDA. That is unprecedented. That is more than the previous 20 years together. What does that translate for these community oncologists? They see from breast cancer to lung cancer to melanoma to ovarian, they're general oncologists. And so the NCCN guidelines for standards of care have quadrupled or 10 times, depending on the cancer. So to keep up with it, on top of that, they see 20 to 30 patients a day. They work 12 hours on average a day. And they oftentimes have to work on a weekend to catch up on their patients' paperwork, to submit for billings, and also their own business, right? Or if they work for a health system, if they are involved in research at all, they have to use their own time to write papers. So on the research side, there are 13,000 medical oncologists licensed to practice in this country, plus the other oncology specialists, maybe 20,000 total. We're talking actively participating in research, meaning running trials or being co-investigators or publishing papers, 15 to 20% tops. So 13,000, do a little math, let's say 20,000, that's 20%, that's 2,000 to 3,000. So 10,000 oncologists generally are not actively participating in research. They're taking care of patients. It's important, right? 80% of patients they're taking care of. And so that's where the majority of patients are. Let's find out where the patients come from that participate in clinical trials. At these research centers, most of them are academic research centers, but they could be non-academic, but most of them are. 40 to 60% of patients are asked or are participate, not just asked. Just about every patient is screened and asked to participate in the clinical trials. The end result is 40 to 60%, depending on the institution and center, participate in trials. On the other hand, in these vast community practices, it's less than 1%. Now, do they want to be involved in? 60% of patients not even asked. 60% of patients, eligible patients, I'm not talking about all patients, eligible patients are not even asked because the providers don't have time, they don't have the awareness, and they worry about losing their patients, right, to other practices. So we did a survey. We've been talking to community oncology. That's our mission, is to help the community access. What we found out, top 3 barriers for these community oncologists to refer their patients to trials. Number 1 is awareness. As you said, Chet, they don't know, they don't have time to find out. They don't have time to find out the value of innovative therapies that maybe they heard about, unless they go to a conference and they're staying and plugged in. Number 2, of course, they worry about losing their patients, the practice. And number 3 is no time. Those are the 3 top barriers. So what are we doing about it? We are bringing, and we talk about this being very geography specific. So for different geographies, there are different configuration of practices and centers and research. So we're building a digital infrastructure to link non-research community oncology practices with research. And that's one of the gaps these non-research oncologists tell us. We would love to have direct communications with researchers and research centers. And therefore, we can have the information flowing. Therefore, we want to do the right things. On average, these oncologists say they should be considering 20% of their patient population for research. Instead, only 1% get enrolled. So that's the gap. That's the part we're working on, building that digital infrastructure to share data, share communications at point of care to help patients.
Thank you. I want to jump to Sid. So Rose, she did a good introduction of a lot of the barriers that physicians are facing. Can you share some examples of what Johnson & Johnson is leveraging, how they're leveraging real world data to drive and optimize site selection, patient recruitment, and just the overall, like we said, improve diversity in clinical trials?
Yeah, just been excited about all this conversation already, the amount of work that's going on. So super proud of the colleagues and the work we're doing. And as an example, to me, this starts with planning. It's too late to start to expect that we will get the patients recruited, the diverse patients recruited once you have started the study, right? So we're starting from the trial design. And what gets measured is, what you monitor, and then that's what gets improved. So we're really grateful that FDA has come up with this guidance, but we were starting on this journey well before that. We started setting benchmarks for how many patients we need to recruit from diverse populations using real-world data based on the prevalence of the disease. Starting with that, you look at the opportunity within the trial design. Patient burden is a huge issue, and especially to your point, diversity is important, but inclusion is just as important, if not more. If the patient burden is too high, especially for diverse communities, especially for African American population, Hispanic population, where they have to travel 2 hours to get to the research center, or they have to take time off multiple times because the protocol is designed as such that they have to have multiple biopsies or multiple visits, that reduces their participation even if they enroll for the study. So in order to address all of this, we're taking a very holistic approach, using real-world data, using data for historical trials performance from research sites, combining that all together. And I think there is a little bit of optimism in the results we're seeing. And so we built our in-house AI/ML driven platform called Trials360.ai, and the recommendations that are coming out of that engine, so to speak, we're seeing about almost 2 times higher enrollment from the sites that are recommended through that platform as a top 50% of the sites that are expected to recruit diverse population. So we're seeing that in oncology. We're seeing that in immunology. We had very high bar set for recruitment, and especially across our immunology trials, about 6 studies, we were looking to enroll about 580 individuals with diverse backgrounds, and we came ahead of that target, 5 months ahead of target in reaching that goal, as an example. And just to the point about the participation, I think Sri did an amazing job. Why is it important to have the diverse population? It's both the right thing to do morally, ethically, and for what we're trying to bring the drug to the market. Because if we don't have the right patients in the research, we won't know what the adverse impact would be. We won't know whether the treatment is as effective for that population. So another study, I know there's been a lot of data that just talked about another meta-analysis that was done for multiple myeloma. Across 430 or so studies, the participation of the African American population was 4.8%. That's much lower. That's between 2012 and 2022. And just by the efforts I'm talking about, being more proactive, being actually intentional about bringing these patients into research, using the data AI/ML. Gary made the point earlier in his talk about 2,500 zip codes containing vast majority of the population compared to 38,000. We have that data, right? So how do we harness that data, make that available to our clinical and operations colleagues so they can prioritize the sites with both the right research experience and also that have the centers of population, but around this idea of connecting research sites with practices, the idea of using a referral network. How do we ensure that, okay, there are sites that have patients, but they don't have research capabilities? How do we connect those research sites with the sites that have the patient population? So I think it's one solution won't address any of this. It's data alone is not going to solve for all this. And I keep coming back to my own experience as a patient. My physician is in Boston. I'm south of Boston. And anybody that has been in Boston has gone through the 93 traffic knows it takes an hour, at least hour and a half, to get to Boston. And if I had to make that visit every 6 months, at one point it used to be every month, not happening, right? And so 90% of my visits in the last 6 or 7 years have been televisits. And now I only go for either a medical procedure or tests that cannot be done virtually. So why can't we bring that innovation? It's not even an innovation anymore in my mind. It should be the standard of care to be able to bring these technologies to our patients where they are, rather than keep asking them. And again, I'm privileged enough to be able to take time off to do this. A lot of the patients we're talking about are not that privileged, cannot take time off. So how do we bring all these solutions together in a way that solves for this problem? We're starting to solve it. There's a lot more work to do, but I think the intent is there, the solutions are there. We just need to bring them all together.
Can I just add something to that, which is interesting? You think about just foundational things like e-consent,
right,
or telemedicine. There's some interesting stats that I think would be useful to share with you around telemedicine, for example. And McKinsey study, for example, found that 70% of potential participants, right, in clinical trials live more than 2 hours from the actual trial site. And so if we can eliminate that barrier, right, through things like transportational challenges, travel time, et cetera, that's a good thing. Up to 40% of clinical trial participants don't complete a clinical trial. And why is that? Because if you use televisits, you're going to ease the burden on the participant, right, of ensuring they stay in line with the study protocol. And I'll also say that sometimes there can be quite a bit of communication between the study staff and the participant when you have that connectivity with telemedicine. So it sounds simple, it sounds basic, it sounds foundational, but it is the key to ensuring that we're enhancing and improving the process.
Yeah, just on the point about just not e-consent, even consent itself.
Correct.
We need to make that more accessible.
Correct.
I mean, most of the consent language you see, and that's something we're proactively working on. It's not as easy because there are regulatory requirements, there are other requirements, but we have to make it easy for participants. We do everything possible as an industry sometimes to not, but I think the wheel is turning, and I think there is that recognition that consent, or how do we, social determinants of health data, how do we use that to bring transportation to them? So the number of things we can do.
Right, exactly. Yeah.
And I want to add something to what you just said about telehealth should be standard of care. And because this is a body that has policy experts,
yes,
it is a big barrier.
Yep.
When COVID happened, we got that emergency allowance for providers to cross state license to do telehealth. That has not been put in permanent state. That is a big problem.
Yes.
That prevents. So that's where, one problem we collectively should make a lot of noise on the Hill and make that change.
Rose, one thing I did want to mention too, Rose, you mentioned, your personal story, and we all have ours as well, unfortunately, sadly, regrettably. But it empowers us to want to do more in terms of this. And it's kind of interesting, in terms of even looking at your bio and your background and so on. We think about this challenge we have about a one-size-fits-all approach in clinical trials or clinical trial recruitment, et cetera, and what we need to do to change that. And when you look at oncology in particular, you look at precision medicine, and the fact that it is not a one-size-fits-all approach, but that every patient has to have the right medicine at the right time, in the right place, with the right biomarker, in terms of what you're trying to treat, I think is really an interesting point in terms of that nuance as well.
Yeah, and this is where digital and data
Yes.
really play a bigger role. And I really applaud what Chet was saying. Again, personal story, when my late husband, was diagnosed, we went to 2 different healthcare systems. We got 3 different navigators. It was not the fact that we didn't have navigators. It was none of the navigators was really navigating from our perspective. It's from their healthcare system perspective, their insurance policy perspective. So I think the innovation you bring to the marketplace is very sorely needed.
Thank you. The other thing too,
I just want to prompt anyone, if you have any questions, you can begin standing at the podiums, and then we'll prepare for those in a few minutes. But you could go ahead, Shay.
The one thing that I build on that is when we think of ecosystem and navigation or clinical trials, we tend to think of all the medical aspect of it, of getting the right biomarkers, of getting the right treatment, and so forth. But the ecosystem for the patient is much more complex. It's all of the community organizations. We have, I think, something over 300 community nonprofit organizations that can help with co-pays, that can help with transportation, that can help with food, that can help with all of these other aspects, right? It's also putting together all of the different connections, definitely, the treatment part of it, but then all of the other aspects, the aspects for clinical trials, because to your point, clinical trial there's a commitment of time and effort and information to be able to complete that. And you need support to be able to do that while you're also, you're also dealing with cancer. Oh, that's right. You also have to do all of that. Being able to have an ecosystem that's that big and that's coordinated, I think is really central to being able to help people to achieve that.
Thank you all so much. We'll start on this end.
Hi, my name is Todd Albin. I'm with Cedar Health Research, and we operate a clinical trial site network that's trying to expand clinical trial access into diverse and underserved communities by partnering with community health physician practices and setting up a research operation for their patients. And in my experience, we've been trying to address the ability to increase diversity on trials, even before the FDA mandate came out. And what we've seen, is that all the statistics show that the best pathway for a patient to determine that the clinical trial option is right for them is if it's introduced from their treating physician. But the challenge that we have is that even if you identify a qualified physician in the community who has interest in being a principal investigator and you surround them with a qualified research team, you can't get them selected as an investigator on the trials because they don't check the box in terms of having prior experience. And this is, it's almost like a resume screening thing that goes through during the site selection process. They're immediately excluded if they haven't demonstrated that they've been a principal investigator, on these studies. So that challenge, I think, is really the biggest barrier that we're seeing in terms of on the ground, in terms of trying to expand clinical trial access to these patients through their practices. And I think the other downside of this is it's really impacting study design, because I think what happens is a lot of pharma companies are consulting with key opinion leaders that are operating at academic medical centers and don't really see real world patients that are going to be the ones that are going to be exposed to these drugs. So if you include these diverse investigators from these community clinics as PIs, you're going to get that input on trial design early and have a trial that's set to succeed in including these folks and getting them through to completion there. So just understanding your comments on that in terms of what the industry is kind of doing to address this, because I haven't seen a lot of movement in this. I've seen a lot of emphasis on technology and decentralized trials and all these things, and remote tools, and all this is helping, but what it's not helping is growing the actual population of diverse investigators who are in the community seeing these patients every day.
Can I just say a few things to that? And I'm not a scientist and I'm not an R&D guy, but I will tell you that we have been doing a lot to, or at least thinking about and acting on doing a lot to address that particular point, because it's a very important one and a very salient point. One of the things that I will say is that, we fully support increased diversity among, you talked about principal investigators, but also just in general, working to identify investigators with inclusive research practices like translation services, extended business hours, offices near public transport, to increase that diverse patient access. But I completely agree with you that it is a challenge, and I don't think we've really solved for it yet.
So just to add to that, I think that's a fair point. And, because we do quite a bit of work on algorithms and, selecting sites, et cetera, part of the requirement is, at least has been, does the site have the research experience, prior research experience? Now, what we have started to do, part of the reason to bring a lot of this real world data is to also bring does the site historically has patients? And typically, you do see a consolidation of minority populations in areas where there are either physicians or investigators with that diverse background. And research shows that, just on the trust issue, that they're more likely to be able to get these patients to participate in the studies. So we are taking steps to, even though we are data-driven and we're trying to make a lot of those decisions based on that, add that additional element of data and then go beyond just the prior research experience. Is there additional support we can provide to be able to get that site research ready? But also the idea I talked about of research networks and being able to work with those physicians to have the patients be referred to at research sites. But I think it's a combination of both that we have to do, and it's not fully solved, but we're aware of the challenge.
Yeah, no, I think that dynamic that these research networks that have the experience and the team members, and they might have medical directors and supervisors of other physicians who know how to teach them how to be PIs. Everyone knows who's done clinical research. The PI is important, but it's the coordinators
Right.
and everyone around them that are carrying the burden. And as long as you can surround them with those folks, you can, I think, be assured the studies are going to be well executed. And I think that just, it ends up being a barrier that it doesn't realistically impact study performance at the end of the day.
Thank you.
Thank you. On the side.
Good morning. The panel did a great job highlighting. So first of all, my name is Donnie John. I'm the executive director of NovaScript Central. We provide life-saving medication and health services to the uninsured and underserved in Northern Virginia. The panel did a great job talking about the importance of diversity in clinical trials and reducing the patient burden. So the question I have is, when do we start talking about the focus on affordability and accessibility of these new therapies for minority communities? Because what good is a diagnosis if you can't afford to treat it?
Awesome question.
I mean, that's again, a very good question. Part of it is, when we specifically focus on the research, and that's where the R&D focus comes in. I'll also, from a commercial perspective, let you address this.
Yeah.
From a research perspective, I did talk about, we recognize the burden from even getting to the research itself, right? And how do we minimize that gap? So we actually know, even before we talk about affordability, whether these treatments are effective for that population or not. I'm not on the commercial side, but I do know we are working, there's a proactive effort to how do we support and provide the right level of support for different treatments that frankly could be beyond the reach of certain patients. There's a number of different programs, but not being from the commercial side, Shri, if you want to add something there, and I'll pick up.
I will say this. I mean, first of all, thank you for the question. It's a really important question because affordability and access, to your point, you can have the greatest medicines in the world, but if you can't get them to the people who need them, what's the point? And we do. I mean, listen, a lot of us have programs like patient assistance programs, for example, to, based on certain eligible criteria for people to qualify to get medicine, sometimes at no cost, or at a very reduced cost, depending on, what the factors are. But I will say this, and I say this not to sound defensive, but actually to agree with your position. We need to do more, a lot more. And do we have the answers? Some, not all. And this is where partnerships are also important with the community to really understand what's driving the inability for somebody to get a particular medicine. And there's been in the past, we've talked about, the high costs of drug development, yada, yada, yada. But I will say that we're constantly thinking and working on how we're able to address this access issue because it is still, in my opinion, a barrier to getting good health care for all.
Yeah, it's one of the biggest reasons why people don't participate in clinical trials, because they don't see how they can afford the new discovery that happened based on them providing their assistance. So when we look at the All of Us study, looking at the altruistic behavior of giving your DNA for research, but then the research that's just done on your DNA is no longer accessible for you or your loved ones.
Yeah.
So, and the number one
That's a great
reason for personal bankruptcy is medical bills.
Medical bills, exactly.
So the high cost of cancer treatments causes an extensive amount of financial toxicity that people can't break out of.
I agree. No, I agree. It's an excellent point. It's an excellent point.
We'll take one more question.
Yeah, along the lines of what we need to do more. My name is Dr. Judith Flores. I'm here representing the National Hispanic Medical Association. I'm also long-term clinical leader in healthcare delivery. My big question is, what has been your experience in effective interventions, and including people who have limited English proficiency and have other cultural issues and barriers, and I'd say opportunities to get them enrolled? I mean, we have the economic issue, which I definitely support what was just said. But in addition, you have people that come from communities that are not speaking English, that are not involved in the greater community and culture that you're approaching. So what has been your experience in being effective in these areas?
Well, I would say from our perspective, that's one of the wonderful things about telemedicine, right? And our telephone communication is because you don't have to have one person in one location that speaks that particular language. You can have one person anywhere in the country or the world that speaks that, right? So what we do is we have a number of people with a number of language skills on our staff. But beyond that, then we have access to translation services that cover, I think, 150 different languages, so that we can have communication through that channel. And because you're exactly right. I mean, I was telling someone earlier in my career, I was in education, and the first elementary school that I worked in, there were 25 languages spoke in that elementary school, right? Which, when you think about with children, these children have no English as second language skills, right? But you're not going to be able to get 25 translators in, right? But through telemedicine, through remote connection, you can connect with people that are very fluent, that are able to provide that service. So I think the technology here can be a real benefit to be able to begin to address some of that.
Anyone else want to?
And I'll add to that is, I think it starts with a provider. What we have seen is certain cultures, let's say natively speaking, Spanish speaking families tend to have big family coming to those appointments. And when the provider speaks and they trust the provider, that's where effective enrollment could actually start happening. Planting that seeds, having that intent, and having the entire family there understand, providing education about clinical trials as a treatment option to not just the patient, but the entire family in their speaking, in their native language.
So I will say, I agree with some of what you've said, but I will also say that the use of translators, the use of non-personal encounters is not very effective for certain communities, especially for Latinos. We like to have a personal touch. So having someone on the other line, someone translating visually is not always the most effective way to deliver such important and impactful news to a family. So I would say what you just said is very important. We need to make sure that our providers look like us and speak our language. So maybe that's something we need to support to get people into clinical trials and get them care. So it's not always going to be a translation issue and a virtual issue. It doesn't always work. But thank you very much.
Can I just add one more thing, which is sort of on the other side, the commercial side from where I sit, because we are very focused actually on making sure that we're doing the right education, the right awareness in communities, especially in the Latin, call it Latinx, although a lot of people, my friends say Latino, community. Right. So for example, a disease like shingles, right? A disease like shingles, in Spanish, culebria, witchcraft, that's what people think causes, a lot of people.
Culebrilla.
Culebria, thank you.
Culebrio is something else.
Culebria, thank you. So
there we go.
what
you have
we
to
did,
be careful.
yes, culebria. So what we do is, like we've done some really interesting projects with students at FIU, for example, where they will speak with their families and they will do projects to kind of educate within the family itself, what the disease is, for example, and that there is, that you don't have to, it's caused when you have chickenpox as a child and, the virus stays dormant in your body. We also work with Univision on a number of things to get to the community in terms of education awareness. Now, certainly it's not on the clinical trial side, like you mentioned, with regard to providers and making sure they look like you, et cetera.
Yep.
But it's a really good point in terms of how are you reaching people where they are, but also identifying in a way that makes you comfortable to have that conversation.
Yes, thank you very much. I still think we need to have more providers that look like us, talk like us, and think like us. Thank
Agreed.
you.
100%.
Thank you. So I want to circle back and kind of close this out. Our panelists will be around if you have any additional questions for them. But moving back to our theme, now what? We have the data, now what? What would you like to impart to our audience and on behalf of your organizations and the work that you do? What are our marching orders and what can we do to help improve clinical trial inclusivity with respect to the work that you're doing, like I said, with respect to AI and what Johnson & Johnson is doing? Just some final remarks for us. To start with Sri.
Okay, sure. So first of all, and I don't mean to sound facetious when I say this, but I was talking to Gary earlier, who's such an inspirational figure in the community and certainly his leadership here. I said, I'm hoping that one day we can come here in the not too distant future and say, no more questions forever. The acronym, of course, NMQF. And I think what's really important is to ensure that, first of all, it's been a really robust discussion, and we don't have the answers. You can tell we don't have the answers to everything. There's some really important points that were raised here, which requires us to go back to the whiteboard and do some more analysis. But I think going back to 2 or 3 key things. One, continuing to build the trust in the community. I think the lady who was up here just now, who talked about even the providers and making sure that people look like us, speak like us, talk to us culturally, gel with us, I think is really important. I also want to go back to the point about diversity and inclusion in terms of having both as really important aspects of this. And I think overall, just continuing, I should say, to think about, the challenges, the trials and tribulations that all people face from all backgrounds, and how we can continuously try and be effective in how we address this issue around making, equity a good thing for all and, inclusive for all as well. So that's what I would say.
Thank you. Sid?
Thank you. So amazing discussion. And what I would bring back from an AI and data perspective, I feel very optimistic. First of all, there is recognition of the problem. That's the first step, right? So this discussion shows the problem is recognized and we're working on the solutions. We're not there yet, but we are making progress. And the example I gave, we're already seeing twice the recruitment in some of our major oncology and immunology trials using a data-driven approach that you combine with the right operational approach, the right community engagement approach. All of that combined is already starting to see double of how we bring patients in. More work to be done. But I think the AI and data has the opportunity to transform how we do drug development. And the examples Gary talked about, we need to use the data and continue to use that as a backbone to start to bring some of the other cultural and broader socioeconomic changes that are going to move the needle in that direction. And our CEO recently said that the next 10 years, based on the power of technology and data, have the power to transform healthcare versus what was done in 100 years. So I really am optimistic about where we can go from here.
Thank you. Rose?
It's been a wonderful panel here. One thing I'd say, everybody has heard this, no one size fits all. We as patient, we as provider, we as drug maker, no one size fits all. So beware of the ecosystem, the human actors in the ecosystem, as well as the organization actors in the ecosystem that all come into play. that have an impact on every single patient and every single provider.
And I would kind of build on just to say, healthcare is a one-to-one relationship for each of us as patients, for each of us as caregivers, right? We have an interaction with a healthcare provider in some different way, and it's a one-to-one relationship. In fact, we generally even call them our doctor, or our trial, or our pharmacist, right? There's a one-to-one relationship. And I think one of the great things about what we're doing here is we're broadening the discussion. We need to have more physicians, nurses, pharmacists, navigators, right, from every different dimension that we can. We need to have a much broader workforce, not just to provide services, right, but so that every aspect of providing care is a one-to-one relationship with someone that we understand and trust, right? And technology can help us to move so much more in that direction, to be able to communicate, to relate, to recruit, to learn in ways that we couldn't do before. Right? That's not to say we don't continue to be in communities doing those one-to-one, but we have the opportunity to do those kinds of things now on even bigger, grander scales, and to build on this data that we have from the last 25 years. We have reimbursement now to be able to make that happen, right? It's always one or two steps forward, one or two steps back, but it's an exciting time to be, I think, addressing all of this.
Okay, thank you. Thank you. I want to thank our panelists, our audience for your questions.
Thank you.
impact every community. In the biopharmaceutical industry, developing life-saving treatments and cures, working to help those in underserved communities, and supporting patients in need are all just a part of our everyday life. And we need your help. We're working to provide better access to our industry and to make more opportunities available than ever before. We're offering scholarships to make education accessible. We're putting more resources into our communities and providing support and mentorship to those who need it. If you're looking for a career in medicine, business, or marketing, then you have an opportunity to create change and save lives. We're fighting to drive research and innovation forward while paving the way for progress. And we know this can only be achieved when we fully embrace diversity, when we make it part of our DNA.
So are you in the policy, government affairs, or PR, or for NMQF? Yeah, that's great.
Good morning, everyone, and welcome to our IRA panel discussion. My name is Christina Epperson, and I'm the Health Policy Manager with the National Medical Association. And I'm truly looking forward for the opportunity to be able to share the stage with and learn from these esteemed and knowledgeable individuals about this program. I'd first like to begin with a brief overview of the Inflation Reduction Act. Signed into law in 2022, the IRA sought to provide meaningful financial relief for millions of Americans under Medicare by expanding the benefits and lowering drug costs. Under the IRA, we've seen the $35 insulin cap, inflation rebates, and drug price negotiations. However, many believe that there are still gaps in what the IRA provided as far as adjusted coverage, and that is what we will be exploring today. I'd like to introduce our panelists. First, I have Candice DeMatteis. She has served as the policy director for the Partnership to Fight Chronic Diseases since January 2008. PFCD is committed to both raising awareness of the human and economic toll chronic diseases exact and highlighting solutions that address these challenges equitably for all of those affected. Next, I'd like to introduce Courtney Christian, who is the Deputy Vice President of Policy and Research at Pharma's Equity Initiative, driving pioneering plans to invest in communities of color in 3 key pillars: enhancing clinical trial diversity, developing research and policies that advance health equity, and building a diverse industry talent pipeline. She also focuses on state-based reforms, impacting health insurance and prescription drug coverage in public health programs. Prior to joining Pharma, Courtney worked at the Black Women's Health Imperative as Director of Policy and Advocacy and on Capitol Hill for several years in a series of roles, culminating as Legislative Director for Rep. Kathy Castor. Next is Laurent Carter. Laurent has 30 plus years of executive leadership experience in the pharmaceutical, biotech, and healthcare industry. He has been at Bristol Myers Squibb since 2016, and for the last 2 years, he has led the global pricing organization merging US and WW Pricing, as well as US and WW Healthcare Analytics into one single organization. He has recently taken on a new role as SVP Transformation Lead for Market Access Pricing and Value Demonstration. This role is focused on leading the organization through the evolution driven by rapid globalization of the healthcare access environment and policy reforms to align US and ex-US position, process, and strategies. Finally, we have Susan Peshin. Sue is President and CEO of the Alliance for Aging Research. The Alliance's vision is to create a culture that respects aging as a greater good and values investments that advance dignity and equity. Ms. Peshin has led efforts to increase federal investment in aging research, raise awareness of geriatric cardiovascular disease, develop an older patient and family caregiver research engagement network called Talk Nerdy to Me, nerdy being nurturing engagement in research and development with you, advocate for patient affordability and equity-based value frameworks, and improving Medicare treatment access. I'd like to give our panelists the opportunity to also introduce themselves and tell you a little bit more about what we'll be talking about today.
Sure, I'll get us started. Thank you so much, and thank you to the National Minority Equality Forum for hosting this important session and including me. I'm honored to be here. The Partnership to Fight Chronic Disease really focuses, as our name implies, on the burden of chronic illness both economic and human burden, and looking at ways to reduce that burden to lower healthcare costs and improve the lives of everyone. We did a study in 2021 about health equity specifically, and trying to put a dollar figure on what we're all here talking about, is ways to improve health equity. And we specifically looked at health equity in achieving outcomes, recommended health targets for common chronic illnesses, type 2 diabetes, hypertension, and the like. And we got, this is just among people who are already diagnosed with insurance, so people who are identified as having these diseases in the system and with presumably some access. Just achieving health targets, recommended health targets, would save us $2.7 trillion over 10 years. Now, even by DC standards, that's nothing to ignore. It really focuses on improving access to primary care, improving access to medicines, adherence, and I know we're going to talk a lot about that access to medicines in the IRA today. We know there are many positives, as you mentioned in your intro about the IRA, about lowering costs for vaccines, for example, zero copays, really encouraging people to get vaccinated, and capping out-of-pocket costs for medicines, smoothing out those costs over the year. But PFCD and many other groups, including I think the Alliance for Aging Research, share concerns about some of the fallouts and the potential downsides, particularly with respect to the Medicare drug pricing program. So I hope we'll explore that today as well. Thank you again.
Well, good morning, everyone. I'm here representing Pharma, which represents most of the leading pharmaceutical companies across the nation and even abroad. As you all may know, we spend quite a bit, make quite a bit of investment in the search for new cures and treatments. Since 2000, we spent about $1.1 trillion in the search for new treatments and cures, and just a little over 102 billion in 2021 alone. So our commitment is deep to ensuring that we create medicines from some of our member companies like BMS here and others, so that patients can live longer and healthier and more productive lives. And, you know, to be honest, as we get more into the conversation here about IRA and health equity, some of that development is really at risk with the implementation of the IRA. And it really can have significant impact on health equity as we think about medicines as a way to help patients, you know, treat their chronic diseases, potentially be cured. How might this bill sort of create another barrier to that sort of access to that sort of care so that patients can live those longer, healthier, and productive lives?
So I'll jump in. Laurent Carter, I am the Senior Vice President at Bristol Myers for a transformation lead of global access, pricing, and value demonstration. I've been with BMS, as Christina said, for about 16 years, but I've been in the industry for 30 in various different commercial roles. With respect to IRA, my current role involves working with a team of folks across our organization in terms of navigating the IRA and its impacts and implications from an organizational standpoint, not just the negotiation process, but also kind of the implications from a planning standpoint, investment standpoint, et cetera, for the organization and the industry. As Courtney indicated, this is not a BMS alone issue. This is an industry-wide issue with multiple different stakeholders that are impacted. I was unfortunate in that I was not able to attend the dinner last night, but my understanding was that Daniel Dawes gave a presentation or a discussion around his book, which spoke about policy implications for health equity over the years. And you know, my perspective on that topic and that issue is that this is another example of a history of policy and unintended consequences as it plays out over time. And I think that's a big part of the discussion that we're going to have, is what are the potential unintended consequences that come out of the legislation that was passed. I will just qualify. I am here speaking on my own behalf. I'm not representing BMS as an organization. And you know, there's reason for that statement, because there are ongoing issues with respect to IRA that our company is dealing with from a legal standpoint. So I'll just put that out there.
And hi, everybody. I'm Sue Pesham with the Alliance for Aging Research. And when I was thinking about this particular panel, I thought, zooming out a little bit to where we are right now at this moment, kind of in history, still coming out of COVID, when there were over 900,000 older adults that died as a result of COVID-19, and they're still dying. It is, still here, along with a lot of other infectious diseases and chronic diseases that are a result of folks having to delay care due to COVID. How many people here have ever taken a look at the Medicare Trustees Report in a given year? Anyone? This is the report, and this I learned from Dr. Gary Puckrin, and now I look at it every year. And you could just look at the introduction of it, but it's the report that comes out from the designated trustees on the health of the program itself and on what the anticipated costs are going to be. And back in 2021, the Medicare trustees came up with what they call a COVID mortality index. And what that COVID mortality index represents is the people that were the sickest, the beneficiaries in the Medicare program that were the sickest prior to COVID, were the ones most likely to die during COVID. And as a result, that amounted to huge savings for the program, so much so that it was able to extend the health of the program. And that calculation that they put in place will be calculated until 2029. So that's how much of an impact it had on the program. But that's also the lens through which CMS views its beneficiaries. And it's a good sort of setting point for what we're talking about today. There's no doubt there are good things in the IRA. We're very pleased about capping in Part D, the coverage for vaccines, a whole bunch of things, some of which Candace mentioned. But the issue of direct negotiation really concerns us, so much so that my organization opposed IRA on that basis. And there weren't that many groups that did because there were so many other good things, and it created this very difficult situation for a lot of patient advocacy groups. So I welcome the conversation today, but just wanted to give you that context for what we're going to be talking about.
Thank you all, and thank you again for being here. So let's just jump right into it. First, I'd like to talk about Medicare and price savings, and I'd like to direct the question at Sue and Candace. Medicare price negotiation is expected to save the federal government $98.5 billion over a decade, but whether beneficiaries will see any of those savings remains to be seen. How did the way Congress spoke about the IRA and beneficiary savings from the cost of higher priced drugs differ from the way that this is all playing out?
Mm-hmm. Sue? Sure. Yeah, sure. So when the IRA, I think it's important to remember when the IRA was originally being discussed in Congress, a lot of the conversations were to build support around drugs that had sticker shock to them in the hundreds of thousands. And that intent was not really reflected in the first list that was released by CMS, which tells you quite a bit about sort of where this is going. 7 of the 10 first selected medications that are on the list for Part D drugs treat cardiometabolic conditions. And these medications help patients who are at very high risk of deep vein thrombosis, pulmonary embolism, stroke, and heart attack. Others are used to treat diabetes, chronic kidney disease, and heart failure. And the prices for these drugs aren't trivial, but they're already heavily discounted. So when we looked at the CMS's first list, what made it notable is that millions of Medicare beneficiaries rely on those drugs. So they pick these drugs based on volume and total cost to the program. And what that means is that the potential for harm is greatly increased if access is restricted and if substantial access to access is restricted. And that's what we're concerned about. Candace?
Sure, and I'll add to that a little more specificity. Gross price, and this was the price that Medicare put out for these drugs that Sue's talking about, 7 out of the 10, is $400 or less a month per person for Medicare. So again, it was driven by volume, not price, even though that's exactly what they were talking about in terms of touting the program during the debates within Congress. So the problem is when you are targeting drugs that are driven by volume, you've got to deliver those savings, you've got to address the volume. And that means access for beneficiaries. And that's really what's raising a lot of concerns. The other thing that's really problematic, as you mentioned, 7 out of the 10 are in a disease area where there are common comorbidities. You could easily have one person who's probably taking multiple of these medicines. What is that going to look like on formularies going forward? What is that? They may have barriers to access not to one of their drugs, but 3 or 4 of the medicines that they are relying on to treat these very common chronic conditions. And that is also problematic. The IRA requires plans to cover these meds if they're part of the drug pricing program. They don't stipulate they have to be on the lowest cost sharing tier. They have to be provided without step therapy or prior authorization. And the way the market works with drug pricing, those savings will go to the government, whatever cuts they put in play on the price of those medicines. But if you're a PBM or a plan and you get the benefit of the discounts that you negotiate, you're probably going to favor the drugs that you're still negotiating those discounts for. So again, not really understanding the market that well, and we're really concerned about what that's going to look like in terms of access for beneficiaries for a lot of these very common chronic conditions and co-occurring chronic conditions.
Thank you. Pivoting just a little bit, I think that we can all agree here that health equity is the goal. I think most of our organizations, we would say that that's a priority personally and on a professional level. So Courtney and Laurent, what is the potential impact of IRA on medical innovation and health equity?
Yeah, you heard me talk a little bit in my opening about how much investment our member companies put into medicine development. And really, with the implementation of the IRA, we really see that investment sort of being at risk, right? And at risk to patients who are, as you've heard Candace say, and Sue say as well, at risk and have, just a myriad of, chronic conditions that they're trying to control. We did a survey of member companies, and 63% of them said that as a result of the IRA and its implementation, they're going to have to think about their investment a little bit more closely. They're going to have to think about whether or not they invest in small molecules, and they may shift away from that as a result. 82% of these companies also report sort of a really substantial impact to the pipeline of medicines that they already have in the pipeline, right? For everything from, mental health medicines to, rare diseases to infectious diseases. So, it's really impactful when you start thinking about it at the pipeline level. And we know that medicine development, it's not a snap of the finger, kind of overnight development. It takes 10 to 15 years to bring a medicine to market, to bring it fully through, the clinical trial gauntlet, right, to FDA approval. And so, that's not something that's insubstantial. And also, once they get to that FDA approval process, really only 12% of medicines actually make it over, make it to market. And so when you start thinking about the risk to, development and investment, that's not insubstantial. It's not small. That's not inconsequential at all. And these medicines, when they're brought to market, it may just be for one indication, but when you get to the post-approval process, you find many more indications that might be helpful, many more indications that might help address a chronic condition or cancer or some other sort of treatment. And so, I think as a result, IRA is really driving difficult decisions within companies. I know Laurent's here as himself and not as BMS, but for many of our member companies, it's really driving, sort of difficult decisions. Resource reallocation. Where do you place your development? Where do you think about what you do next? What do you think about the pipeline? And to bring it to health equity, who bears the brunt of chronic conditions the most? Black and brown communities, other underserved and marginalized communities. We're the ones, I think as the saying goes, when the majority population catches a cold, we catch the flu, right? And so that is where the impact lies. And, Candace, alluded to the PFCD work last year that showed that we could save $3.8 trillion just by empowering patients to be able to take more control of their health, making sure they have access to medicine. So that's, I think, about $2.7 trillion in saved medical costs and $1.1 trillion in savings to lost productivity. So, I mean, you know, I think that's what we're getting at, you know, that we know that better disease management, access to medicines helps, you know, mitigate chronic disease, help people manage their chronic conditions, and just helps them be able to be productive members of society and, you know, engage with their families and enjoy them.
Yeah, so I'm going to build on what Courtney was saying with respect to investment from an industry standpoint. Similar numbers coming out of, I believe, the same survey, talking about investment or looking at investment in new uses for medications. And this one has a particular passion for me, and I'll explain why in a second. But 95% of pharma biotech that participated in the survey said that they are reconsidering or will be reconsidering future indications for medicines going forward. And if you think about the development process from a medication standpoint, Courtney hit on some of it. One, to get to market is a major investment, takes a lot of time once you get the product approved. Then most companies look at what are other applications for that product. Can we use that product to help other diseases, especially if you look at oncology as an example. Typically, you'll get a first indication, and then it will expand to look at other tumors, other types of cancer, other stages of cancer. And the problem is with this legislation, you start a clock ticking at the date of FDA approval that limits the amount of time that you have to be able to recoup that investment, quite frankly, in terms of the cost of investing in a clinical trial, which is multiple years, 3, 4, 5, even 10 years in chronic diseases. And if you look at the time frame from which a product gets approved and from when it gets negotiated down to a minimal price in this system, it's 9 to 13 years. So as a manufacturer, am I going to start a study 7 years into the life cycle of my product that I won't be able to recoup the investment in? No, I'm going to take that investment because I'm a business and I'm trying to look at maintaining that business so I can continue innovation. I'm going to look at other products, other indications. Why is that important? And I'll give you a personal story. So my wife was diagnosed 3 years ago with metastatic stage 4 cancer. It was a misdiagnosis issue that ended up finding me there, or finding us there. Fortunately for us, there are numerous medications that have been approved for this particular cancer that she has the opportunity to use over time. That was 3 years ago. Her life expectancy is quite good right now. So, you know, that's because those medications are there. Those medications were 5th, 6th, 8th indications for the medications that were developed. No one would invest in those clinical trials today for future medications or future indications of other medicines. So for patients that are disproportionately diagnosed in late stage disease, the ones we're talking about here, those products, those indications will not be invested in and will not be available in the future. That's a travesty, and that's an unintended consequence of the IRA as it goes to innovation of medicines going forward. The other thing that I point out is that timeline, that clock that I talked about. It's differential. So for pills, right, it's 9 years. For injectables, it's 13 years. So there's a inherent disadvantage to oral medications that makes no sense at all. And quite frankly, for disproportionately impacted populations, taking a pill is a lot easier than doing that long commute that was talked about in the previous session. Hour and a half, 2 hours, 3 hours, however long it is, to get to a major medical center to get an infusion as opposed to taking oral medication. So I think it's important to recognize that there are consequences because of the system that we have in terms of what the differential investment will be and what gets developed from an innovation standpoint, from a product standpoint going forward.
And I have to say, Courtney, the analogy of saying other communities catch a cold and minority communities catch the flu is, I'm going to be using that analogy forever because I mean, I just think it speaks directly to what health equity is.
Yeah.
And Laurent, I know that you are representing yourself today, but if you could tell us how BMS is addressing health equity and how does the company view the role of private-public partnerships in driving progress?
Yeah, so I think it was said in the previous session as well. Nobody does this by themselves, right? Everybody has to participate. Everybody has to be focused on improving the situation where they can, and they can't do it alone. So it has to be done through partnerships. And if you, BMS just recently actually published our environmental social governance study, I think about 2-3 weeks ago. And it shares a lot of information in terms of the investment and contributions that we have been making as a company in terms of this area. As an example, in 2023 alone, we made $19.5 million worth of grants over 277 different organizations worldwide, impacting over 12 million patients in terms of providing additional services, education, and vehicles to help them in terms of seeking medical care, seeking medical education, access to healthcare, et cetera. So, the commitment is there, but BMS is one of many. And every one of my colleagues that was on the first panel, I'm sure their organizations are doing similar things in terms of investment. But we can't do that alone. We need to do it in partnership with the organizations that are on the ground and that are built into the communities, et cetera. A couple of examples that I'll give you of what those investments or those grants and those types of things have done in the past. So we participated in a program called Hip Hop during the COVID crisis, providing or developing music videos, educational music videos for the Hispanic and for the African American community to educate on treatment, on vaccination, on the importance of monitoring, all of those things. So we could get education to those who weren't necessarily getting it, in the vehicles or in the environments that they would be receptive to. There's also a breathing room partnership that we engaged in, which looked at social determinants of health and helping to address that mobility issue and providing transportation services, et cetera, for patients with lung cancer, being able to get to major institutions from a treatment standpoint. We entered into a partnership with the Asian and Pacific Islander community to partner with 20 different community organizations across 16 states to be able to provide navigator services for the Asian community in those areas, helping to bridge language barriers, helping to bridge education barriers and provider barriers in that area. And the last one I'll mention is Moonshot. Been very active with Moonshot in terms of engagement with clinical trial diversity, ensuring clinical trial diversity, but also in terms of screening and getting local community screening for lung cancer and other tumor types. So I think the desire to contribute is one thing. You can't do it alone. You have to do it in partnership with organizations that are engaged, like the folks that are in this room, in addressing these issues.
Completely agree. And I want to say to your last point, I'm glad that your wife is doing better. And I think that it's really important to utilize, especially as minority communities, patient stories. And also, as you said, to integrate ourselves within the community in partnership with other organizations to really be boots on the ground with these issues like health equity. So Courtney, similar question. How is the industry addressing health equity more broadly?
By doing a lot of the things that Laurent spoke about. Back in 2019, we started looking at health equity and sort of pharma's place in that conversation, recognizing that so many other people before us have been talking about it for a long time, doing the work, but we really started being more intentional about what is our contribution? How can we bring our resources to bear in the conversation about closing health disparities? And then, 2020 happened, COVID happened. We saw the outsized impact of COVID-19, particularly on communities of color. We had all the social injustice issues that were just really bubbling up. You all know with the murder of George Floyd and Breonna Taylor, and just so much going on at the same time. And our CEO came to me and said, what can we do to be better? The status quo is just not working. What can we do? And so together with a team of folks in pharma, we created the Equity Initiative. And it's centered, as you said in my introduction, around 3 pillars on advancing health equity, on creating a more diverse talent pipeline into our industry, and on enhancing clinical trial diversity. And so like Laurent, like BMS, and so many of our other member companies, we've been thinking about how do we invest directly in communities. And so we stood up this Collaborative Actions to Reach Equity grant program where we're funding community-based solutions right in communities. So we've done an RFP on the intersection of SEOH and medicine access. We've done an RFP on COVID vaccine access and hesitancy. We recently just awarded $250,000 in our last round on research to close cancer disparity outcomes and gaps in communities of color. So that brings us to about a $750,000 investment in just community-based work. And we'll be issuing another round of RFPs this year, just really focusing here in DC. But one other thing that we've done in partnership with many of you, but also in partnership with the Morehouse School of Medicine, the Satcher Health Institute there, is we partnered with them on their health equity tracker. I don't know if you all have been able to take a look at it. If you haven't, go to their website and check it out. But we partnered with them on a module on inequitable access to medicines, and we're looking at Medicare data. And so it's been a really fascinating sort of deep dive into inequitable access to medicines nationally. So if you go to that site, you can take a look at sort of inequitable access to medicines, cardiovascular medicines, cancer screenings are going to be coming up soon, HIV medicines and some other medicines. But you can get a look, you can get a high level view nationally of where the access issues are. And then you can look at your state where you live, and you can look at it by the county level as well. And you can see where people are having issues in access to care. And then just last, I'll say, because clinical trial diversity, I think is important to all of us, and a little plug for our EQB Med program. So that is our Equitable Breakthroughs in Medicine Development. It is a partnership that we've undertaken with some academic universities to really think about, how do we change the paradigm and, the usual status quo on how clinical trials operate within companies, and to say, what happens if we just invest in community? What happens if we go into a community and set up in a community and stay? Because one of the things that we encountered when we started our equity work, we did some focus groups, and one question that has stuck with me from one of the focus group attendees they said, are you coming to help or are you coming to harm? And so I think our member companies and we do too, we want to help. We don't want to be that agent of harm. And so, through EQB Med, we're trying to figure out what does it take to make a site ready? What does it take to turn a site from a naive site to a mature site? How do we get clinical investigators there that look like the community that, make patients want to come and be part of that community and part of that site and actually demand to be part of a trial, particularly, for conditions that disproportionately impact us and may disproportionately impact their families.
Thank you, Courtney. Now, I know we talked about some of the benefits earlier, like the $35 insulin cap, but what are some of the potential unintended consequences of the IRA that may impact Medicare beneficiaries when it comes to equity and unmet medical needs? Candace, can I come to you first?
Sure, I'll start. I'm not sure we can call this unintended, but I will add it to that category. Given that CBO also said there will be fewer new drugs because of the Medicare drug pricing group. There's a lot of debate, however, no debate that there will be fewer new drugs. A lot of debate about how big that impact will be. But I think Laurent raised a very important point is, did they even count the ones that are existing but maybe would have new indications? And that, when you look at the initial list of 10, a number of those, and I'm going to talk about a little bit when I testified during the patient listening sessions, a number of those indications, which were the larger indications, are expanded to maybe get them on the list because there were bigger populations taking them, came 5, 6, 7, 8 years further down the road after the initial FDA approval. So what is that world going to look like, for patients, and particularly Medicare beneficiaries, because we know that there's so many chronic conditions, there's so many comorbid conditions for which, indications don't work. Every medicine won't work, or maybe it's contraindicated because of the number of other things that they need to take. I also wanted to raise, PFCD did a survey leading into the IRA about what do older adults who have chronic conditions would define as unmet medical needs. And topping the list were medicines that are accessible and easy to take. So those small molecule medicines that we've been talking about, the pills, the syrups. Think about someone with arthritis or a disability. The ease of administering for a caregiver or for self-administration is really important. So those easy to take at home, a patch perhaps, something that can be picked up at a local pharmacy, something that could be mail ordered to the individual is really important. And they consider that a significant unmet medical need. They also agreed that medicines that address health needs for people disproportionately affected. So getting right at the health disparities and need for medicines that address health disparities and improve equity. But then again, if you look at the first list of drugs, the multiple are these small molecule medicines, the ones that people want. They address issues of equity. These were diseases for which significant health disparities exist in prevalence as well as in poor outcomes. And so those are all unintended consequences when we talk about what access is going to look like. Are they going to face more step therapy, more prior authorization that puts these existing medicines out of reach, and then also the potential for future medicines and the lack of new drugs, new indications for existing medicines have raised those concerns as well.
Yeah, sure. So in addition to selecting drugs for direct negotiation, another big piece of the IRA was restructuring of the Part D benefit program. And so what do we mean by that? Well, that has to do with who owes what, right? So how much falls on your insurer's costs if you have a Part D plan in the Medicare program, how much falls on the actual Medicare program itself, and then how much you have to pay out of pocket. And of course, we're excited that there was an out-of-pocket limit. There was also getting rid of the catastrophic phase. So when you reached a certain point in the benefit and there was basically no ceiling to how much you might have to pay, that was closed, which is terrific over time. But what happened as a result of that is insurance companies ended up having more liability. And at the same time, Congress said, you're going to have this increase in payment. So just to give you an example, just even in 2025, next year, this starts, they used to have to pay 15%. It's going to go up to 60% of costs in that program in 2025. So it jumps quite a bit. And at the same time, Congress said, but we also don't want you to raise premiums on beneficiaries, which is a typical place where they would say, we're going to recoup some of the costs through raising of premiums. And if you have, relatives on Medicare, premiums in general they're pretty manageable. For a lot of times people pay a lot less because, many of us go on fixed incomes when we retire. And in most surveys of Medicare beneficiaries, they're pretty satisfied with what they end up having to pay out of pocket. And then there's assistance if you need it. That was also expanded as a part of the IRA. But payers won't be able to do that. So then how are they going to recoup these costs? Well, a lot of times when you go to the doctor's office, you might have to have your physician or somebody in the office get permission in order for you or your loved one to use a new drug that might have come out. Or they might say, you have to try this drug and then this drug and not do so well on it before you get the latest and the greatest. That's called utilization management. And that is a big way that insurance companies save money. And there is very, strong signs that payers will use more utilization management on these drugs, even though there's this direct negotiation and theoretically the prices are going to go down. The way that they're going to control for the costs of what, is perceived as potential increase in volume of use is by restricting use. So not only will the prices go down and they'll save a lot of money that way, they'll also kind of, double layer it with limitations in utilization management. What does that look like? Well, there's something called non-medical switching, where maybe you were on a particular drug before. The reason why it's non-medical is your insurance company has made a decision that previously was a decision your doctor made. So you were on a particular drug in a class of drugs, and then your doctor says, oh yeah, your insurance company says, no, we're gonna switch you. Your formulary switched in the next year. And now everything has changed. And anybody, I help take care of my mom. Other family caregivers out there, other folks, I see you, thank you. My mom has 12 different drugs that I manage, and I fill her pill box every week. And my mom knows, where's the blue pill? That's, she doesn't take that blue pill. This thyroid medication is also good. But anyway, people can tell, that's older adults may not always know like what every single drug on their list is called, but they know what it looks like. And if something looks funky or something is not there anymore or something like that, if they are cognitively intact. My mom is actually now in the mild to moderate stages of Alzheimer's. So this I'm talking about in the past, she would notice. And, that introduces problems with adherence and people just quitting medication. And the people who rely the most on the programs, who depend on this income-wise, they're the ones that are going to be most affected by these utilization management techniques. So that's what we're really worried about. And then on top of it, a lot of patient advocacy groups like ours, PFCD, and others have gone to CMS and said, you need to put strict guardrails around this so that payers aren't allowed to do it. And they've said, oh, no, we'll just watch it. Like, we're just going to sit and watch it. And that to us is a sign that it's a little bit of a wink and a nod. We know you're going to do it. We're going to look the other way. And we're gonna continue to harp on it, but we need everybody in this room to do the same. And many more groups need to get engaged in this process along with us in order for us to push back against CMS and make sure those strict guardrails are in place.
Christine, if I could just jump in right here and kind of double down on this utilization management issue. There was a recent Health Affairs article, and I'll tell you all what it said. It shows that Part D plans are indeed increasing utilization restrictions on medicine. So the total number of drugs that have already been excluded from formularies grew from 20% to 30% in 2020. In the same time period, the issue of prior authorization and step therapy on formularies, the number of drugs subject to those sorts of tools, management tools, has grown 5%. So, what you have here is, these tools getting in between physicians and patients, and physicians are reporting, this is, causing a lot of administrative burden for us. It really imposes a lot of undue restrictions, but also it's affecting our clinical decision-making, which has real life implications. And, I'll just say, my dad is a 14-year heart transplant survivor, 14 years this March. And he's on anticoagulants, which is a class of medicines that is subject to price negotiation. So, he's a senior, Part D. What if his medicine changes? What is the outcome? We've known for 14 years that this particular medicine works for him. What if now, due to government price setting and negotiation, they say, no. We're going to switch you to this other medicine in this therapeutic class, which, by the way, there are only two medicines in the therapeutic class. And what if his health outcome changes after 14 years of survivorship post heart transplant? So I think those are real questions and issues that, sort of each one of us need to be pondering as we think about what IRA implementation really means.
And I appreciate you putting the physician perspective in there. As we spoke about before, working for the NMA, physician perspective is very important. And I want to circle back really quick to, you were talking about the listening sessions that you participated in, Candace. So last fall, CMS held a series of stakeholder listening sessions on the first 10 drugs selected for Medicare negotiation. Candace, as I said, you participated in them, and you participated in 9 out of 10 of the sessions on behalf of the Partnership to Fight Chronic Disease. What was your experience, and what do you think CMS needs to do differently moving forward?
Sure, so that was fun.
To say the
First of all,
least.
thank you to all the advocates who lobbied CMS to actually have patient-focused listening sessions, because as you may recall, they were not going to do that, but they did. Unfortunately, it was a little clunky. You had to submit a separate form for each session that you wanted to, potentially be selected to participate in. There were lists of topics on these forms. It was a pretty long form. They started with very clinical subjects. So if you were a patient and maybe like, oh, I'm not sure, I'm not going to talk about any of that, this isn't for me, or I'm not the expertise they're looking for, you would have dropped out before you got to the more patient-focused questions, perhaps. Very few sessions had a full slate of speakers. I think there was one I was an alternative for, and then I actually got selected. And even that one, I think they had one open spot at the end of it. There were also other people who participated in multiple sessions. So again, that speaks to the lack of participation, I think. I think a lot of that is on CMS for how clunky the process was to sign up. There was a real lack of diversity that was just disheartening, candidly. We talked about how so many of the medicines were cardiometabolic, where there are huge health disparities and huge disproportionate impact on communities of color, but not a lot of diversity in terms of the voices represented on those sessions, which was, again, I think lack of notice, lack of opportunity, and people understanding that they could participate. And there are a lot of great models in the federal government to facilitate patient-focused listening sessions and the like. PCORI is a great one. They've been in existence for a long time. They do it really well. FDA has patient listening sessions. So CMS didn't need to recreate the wheel, but unfortunately, I don't think they looked to them for guidance. It wasn't apparent anyway if they did. We also would love to see them adjust the process to provide more opportunities. Right now, we're in this black box period that every once in a while we hear something, we know something's going on, but it's very private, and there's not any opportunity really for the people who are actually going to be affected ultimately, have access restricted, pay more, maybe get switched to a drug that doesn't work for them, and not get those opportunities to weigh in. So we really hope that CMS will look at that as well. At the end, it remains to be seen how much these sessions really will impact their decision-making. I hope it wasn't just a check-the-box exercise, because that'll just drop participation even more. But those are some of the reforms I know National Health Council and others are working to advise CMS about ways to make it more patient-friendly, to engender more opportunities and more diverse voices, as well as the frequency of these inputs. So we hope they're listening. Sue, I don't know if you've heard anything more. Are they?
There's no indication so far
Yeah.
that there's much, different that they're going to be doing. And we had similar experience to Candace. We participated in 2 of them. Even if they didn't have a full slate of people, everybody got the same amount of time to speak. They would cut you off. And, yeah, it was very it was very perfunctory. It was not anything that it seems like they're going to do anything with. That being said, it is important to show up.
Right.
And, more people need to get engaged, and we're going to work over the next several months, pushing folks, encouraging folks to do it anyway. Because if you don't show up, then that tells CMS nobody cares.
Right.
And you got to be at the table.
And hopefully with both of you talking about it, that'll raise awareness even in this room for people to be able to show up and participate going forward. I want to talk a little bit about the pill penalty and give you all an opportunity to explain what that is. What is the pill penalty in the IRA, and why do you think Congress needs to fix it? Sue, would you like to start?
Oh, sure. I thought
Or Courtney, either one.
Laurent get started. Yeah, I mean, simply stated, what the legislation says is that for oral medications, the time from FDA approval to eligibility for negotiation is 9 years. For biologics, which are typically injectables, it's 13 years. So there's kind of this arbitrary differentiation in terms of the length of time just because it's a pill versus a biologic. There's no real logic to it in terms of what the rationale for that differential is, but it has a significant implication in terms of the viability of oral medications long-term for additional indications, investment, et cetera, as I said before. So that's one of the issues that I know we have had with the legislation as it was written, and I know others have spoken to it as well.
Yeah, I would just double down on this issue of oral medications and how important it is when patients can get them at their pharmacy and they can get them through mail order and take them at home, because it really does cut down on some of these barriers to medicine adherence that we see, particularly, around transportation, which is a social determinant of health. Whether or not you have transportation to even get to the pharmacy, particularly when we are living in a time when 40% of US counties are a pharmacy desert. That is to say that, people have to drive 15 minutes or more to get to their local pharmacy. And so this issue of oral medication is super important in maintaining those chronic conditions, and, the arbitrariness of this approval. This time period is really concerning for that reason.
I just have one more quick comment on that. I don't think it's as arbitrary. I know that we, tend to say it's sort of arbitrary. I think that because of the volume issue, they do tend to be less expensive. Oral medications are less expensive, so more people take them. So if you can sort of steer manufacturers away from making as many, then you can, cut down your costs even further in the Medicare program. And the last thing I'll say is the infusion and the injectable drugs tend to fall under what's called Part B in Medicare. So you have to get them in an outpatient center or in your doctor's office. And CMS, some of you may have heard of what they did with the Alzheimer's therapies that came out. That they restricted them, you have to participate in this registry, all that. Really, beneficiaries have to participate in a clinical study. You have to go to an academic center, generally located in a sort of a wealthier area, urban area, very, very restrictive. Less than 2,000 claims have been processed so far since they put this in place last July for this new exciting breakthrough that the FDA approved, traditional approval. It's, it went through everything. It was printed up in the New England Journal of Medicine, and they've had a campaign against this drug. Well, they opened a door for Part B drugs. So even though manufacturers might be thinking, well, we'll invest now in these Part B drugs, CMS still has this other mechanism where they can crack down on access and on use. So it's a little bit of a trap for industry, and it's something that we're hoping, there'll be more awareness and focus on in the coming years as well.
I just had one other thing to add, if I could. One is there is a congressional proposal out now to fix the pill penalty called the EPIC Act, and it's HR 7174, I believe, but bipartisan in the House. So please take a look at that. The other thing I was just going to mention,
supporting it.
Yes, absolutely. The other thing I wanted to mention is that we also have to keep in mind that there's an international impact to the pill penalty. You think about much of the world, infusions are just about impossible to access. If you think about just the cold storage, the sophistication of the centers that would have to, provide these medicines, versus, a pill, a syrup, or whatever can pretty much go anywhere. So there's, so much research and development is done in the United States, and there's great reasons for that, to the benefit of both Americans and then people living abroad. So I did want to mention that as well, that there's a huge impact internationally as well.
Thank you all. And as we approach our last question, I think we may have an opportunity for maybe one audience question, and I believe there's a microphone over there. So if anybody has a question for our panelists, please do so. Laurent and Courtney, what are the implementation challenges of the IRA that concern you?
I think a lot of the ones that have been addressed here today, right? This issue of, patient access and patient voices at the table when CMS is making these type of decisions. There's a lot of red tape that, as industry, we're trying to unwind and understand, more of the implications of IRA. But if we're trying to figure it out and we've got lawyers and, galvanizing, my nerd department, as I lovingly call the policy and research department, and we're all, trying to, look at the fine print. Imagine you're a patient and you're trying to navigate this. And so just really just concerned about that, like, sort of person level impact of the IRA.
Yeah, there's one area that we have not touched on, and it is an area of significant concern for me from an implementation standpoint, and that is the system through which discounts and negotiated prices, et cetera, will make their way to the pharmacy. In the rush to get this program put in place, CMS has put out an RFP for what they've described in the guidance as a third-party facilitator. New term, new organization. Basically what that is identifying a company or a consortium of companies that can facilitate the mechanism to get the price that the patient pays at the pharmacy. That's every pharmacy in the country, to make sure that every patient has access to their right price, and that the pharmacy in turn gets paid the appropriate discount on the backside. There's a lot that goes into making that work. The RFP has been put out. It has not been finalized yet. The word is that they will be making identifications of potential partners in the next month or two. Folks, it's a year and a half before those prices have to be at the pharmacy ready to implement. There's also a smoothing process. One of the nice things about the smoothing process for patients is that there's a mechanism that will enable patients to spread the cost of their medications over the course of 12 months as opposed to getting hit with it all at one point. There's no mechanism to make that happen.
That's right.
Right? The rules aren't defined yet. The physical vehicle to make it happen isn't defined yet. I had a meeting with an organization that's involved in the RFP. I won't name names or anything like that, but they expressed to me, to us, grave concern about the reality of being able to do this within the time frame that is being asked to be done. So my concern from an implementation timing standpoint, and I use the example ACA, if you recall the sign up process on the websites in the first 12 months, this will make that look like a picnic in the park, because you will have patients walking up to the pharmacy and the pharmacy will be giving them the wrong price. And patients will walk away. And the majority of those patients, or a disproportionate share of those patients, are the patients that we're talking about here today. That is a really big concern for me from an implementation standpoint. I think warrants consideration of delay.
Thank you. And I see we have the one audience member with a question.
Yes. Sorry, let me adjust the mic. First of all, the light is shining in my face, so that's what this is all about. I'm Angela Banks. I'm with PCMA, where we represent the pharmacy benefit managers. And so I just wanted to take the opportunity to, first of all, thank you all for highlighting some of the challenges with IRA implementation. I think we would agree with a lot of those. We share your concerns around the drugs that were selected. When the drugs are already heavily rebated, we're probably not going to see a lot of additional savings, which was kind of the point of the legislation. So I think that's one concern. Sue, you mentioned, hi Sue, the issues around rebalancing the liability in the program. And that does put tremendous pressure on Part D plans. And we know that Part D is one of the best, most successful public-private partnerships in history. And so I think we all want to see that continue. And so agree totally with a lot of the challenges that have been highlighted. And really my question is just around, what do you all think is to come? So, looking ahead a year, looking at a new administration or maybe a continued administration, what do you think in your crystal ball we have to be concerned about in this particular space?
And I think that can also tie into, as we're coming up on our time soon, we have the data now what? I think she gave us a really great segue. So if you could all kind of give your thoughts on that.
Yeah, so I'll start in. Thank you for the question, by the way. I think the IRA is having a significant impact on every stakeholder in the system. So clearly can identify with the challenges that are having with the part design, et cetera. Crystal ball. What we're concerned about or look for going forward. I think we've got to still really black hole with respect to the part B, as in boy. This has not been defined. Doesn't go into effect until 28. CMS hasn't ventured into describing what that's going to be yet, and that has many ramifications for providers from a reimbursement standpoint, for manufacturers, and from a cost standpoint for payers from an implementation standpoint. So I think crystal ball is a lot more uncertainty coming forward in terms of the evolution of the program, because it is not defined yet, and we don't know what those are. I kind of described the process of negotiation, going through comment period, and et cetera, and getting the rules for this negotiation that we're going through right now as literally putting the wings and the wheels on the airplane as it's going down the runway. We got changes in guidance from CMS 1 week before the deadline in terms of the submission package that we had to provide. It's that kind of flying by the seat of your pants process that we are going to face now for a while to come. So it's kind of strap on your helmet, and it's going to be a bumpy ride for all of us.
I think that it's going to take a lot of education for beneficiaries, and we're all in on that with the capping and the smoothing provisions, as Laurent referred to, because those are not set in stone yet, what that's going to look like. And then we really want to make sure that beneficiaries start refocusing on their formularies, because a lot of beneficiaries just stick with the same plan or whatever their friends are on year to year. And now that we have these kind of potential shenanigans going on, there's going to be a lot more need to tell folks, you got to have a loved one help you, or if you're able to do it yourself, take a look on the CMS website, Medicare.gov website, whatever. But we're going to be right out there, from the rooftops, letting folks know that they need to watch their formularies. And then the other thing that we predict, which I'm not happy to be a messenger of, is kind of what I started at the beginning of the session. There are going to be people who will abandon medications and will get sick and will end up in the hospital because they are confused or feel like they just are not, they're given the wrong medication. And that's going to be on all of us.
Yeah, crystal ball. I would echo a lot of what Laurent said. This morning before I came here, when I dropped my kid off at school, he said, "Mommy, I know you're nervous, but use your voice. It matters." And so I would say that to all of you all. Use your voice. It matters. In these conversations with CMS, it matters. It matters to us as an industry to hear from patients what it is that you need from us, so that we can recalibrate and think about how we move forward in terms of medicine development. What are the issues that are most important to you as we, try to collaborate with CMS on the best way forward in implementation of this program. There are a lot of what did Donald Rumsfeld say? Known unknowns, or just a lot of unknowns about what's going to happen. And so, just helping us as an industry kind of keep our eye on what patients need, what will be most helpful to you all, as you all are, back home in your various states and your various occupations, and what you're hearing from patients in your community about IRA implementation and how it might affect the people that you know.
I would just say that this is a great example of a larger movement that's going on, and Dr. Puckrin talks about this all the time, and it candidly makes me lose sleep sometimes, is that we're so focused on managing financial risk that we're forgetting that we're talking about people's health, and we're not managing health risks. And that's disturbing. I hope this is a wake-up call. I don't want people to suffer, but that's kind of what we're doing here. And this is another big experiment in that line, and it's really concerning. So I hope it doesn't come to people ending up in the hospital, for people to wake up and realize, hey, we're focusing on the wrong thing here. We need to focus on improving health, and that will lower the costs. It'll give people more equitable opportunities, and we can lower costs that way.
but that remains to be seen, I guess. We have to use our voices to make sure that happens.
I was going to say, I think that's a great way to close us out. I want to thank all of our panelists today. I know I learned a lot, so I want to give them a round of applause.
Thank you.
And I hope that you all learned something today. And in the words of Courtney's child, let's use our voices because they matter. So thank you.
That's right.
Is he 8 or is he 40? Thank you.
Thank you.
Thank you. Okay. I hope he's gonna.
Are all our mics working? Feels right. I love these blue bottles.
Yeah. Boy, those lights.
Gonna be up here like
Okay.
that's a good strategy. I see here.
Good morning, everyone.
Good morning.
I'm LaVarn Burton. I'm president and CEO of the American Kidney Fund. Before we start our session, I just want to take a moment to express sympathy for Congressman Donald Payne, who passed away last week. Our condolences to his family, his colleagues, as well as his staff. Congressman Payne was a tireless advocate for people with chronic conditions, including kidney disease. He spoke and attended many AKF events. We're very grateful for his work and grateful to have known him. For more than 50 years, the American Kidney Fund has been focused on making meaningful changes to address the crisis in kidney disease and help people live healthier lives, with a particular focus on addressing the stark disparities that exist. And I know this is something that's shared by everyone in this room. I want to thank the National Minority Quality Forum for hosting this important panel on kidney disease. AKF is a proud sponsor of the summit, and it's my pleasure to welcome you to this session. AMKD, what is it, who is at risk, and why is it important to our community? We want everyone here to leave with at least a basic understanding of what AMKD is, and we'll get to that shortly. And we also want to leave understanding what we each can do to draw more attention to this under-recognized disease that is contributing to the high rates of kidney disease and especially kidney failure in the Black community. First, it's important to understand that people of all races get kidney disease, chronic kidney disease, and that is at about the same rate. But Black people are much more likely to have diabetes and high blood pressure, the top two causes of kidney disease, and more likely to develop kidney failure than white Americans. In fact, 4 times more likely to develop kidney failure than white Americans. This is a stark disparity and one that is unacceptable. Kidney disease has a devastating impact on countless families in the US. End-stage renal disease or kidney failure takes a physical, economic, and emotional toll, not only on the patients, but on the family and on the community. Today in the United States, there are over 100,000 people who are living with, there are over 800,000 people living with kidney failure. And more than 100,000 people are on waiting lists for life-saving organs, most of them waiting for a kidney. AKF has been working at the state level as well as the federal level to support legislation that would make it easier and encourage people to donate, living people to donate a kidney. We have succeeded in over 32 states that now have some policies that protect people from discrimination if they donate a kidney. We're going to talk about that a little bit later today. We need greater awareness and we need solutions to address the inequities in kidney care. We'll touch on some of these solutions today. including barriers to access to transplants. Today, we'll talk in greater detail about our efforts to raise awareness of a particular form of kidney disease called APOL1-mediated kidney disease, or AMKD. I'm guessing that most people in this room have never heard of AMKD. Aside from those who may be nephrologists or kidney doctors, is there anyone in this room who has even heard of AMKD? Just a few. We hope that that will change after this panel's discussion, because that's why we're here, to educate people about AMKD and to help people become APOL1 aware. The American Kidney Fund is proud to have launched the nation's first ever AMKD Awareness Day, and that happens to be today. So this is an especially proud moment. Going forward, this day will be recognized on the last Tuesday of April, which is also, of course, National Minority Health Month, the month in which this summit is always held. AMKD Awareness Day aims to raise national awareness of this disease so that people will be aware of their potential risk, recognize symptoms, and share information about AMKD and genetic testing. The American Kidney Fund is proud to lead this effort with generous support from Vertex Pharmaceuticals, and we want to thank Mayor Muriel Bowser for officially recognizing April 30th, 2024 as AMKD Awareness Day in the district. And we want to thank Congresswoman Stacey Plaskett for introducing a resolution in Congress for AMKD Awareness Day. In addition, there are 12 states around the country that have also issued proclamations regarding this day. In short, we think it's vitally important that we help people better understand how their genes may impact their kidney health, becoming APOL1 aware. And now let's get the conversation started. With me today are Dr. Margaret Collins, a nephrologist with Vertex Pharmaceuticals, Barbara Harrison, a genetic counselor and assistant professor at the Howard University College of Medicine, Imani McConnell-Brent, a patient advocate diagnosed with AMKD, and Janice Whaley, president and CEO of Donor Network West. So we're looking forward to a very exciting discussion, very informative discussion. We'll start with you, Dr. Collins. Let's talk about APOL1-mediated kidney disease and how is it diagnosed? Additionally, what role does APOL1 gene play in kidney disease? And why does the APOL1 gene variant primarily affect the Black community?
Thank you so much. And I wanted to say happy AMKD Awareness Day to everyone, and to thank you in particular for all the work that you did on that. So this is such an exciting day because I think things are really about to change, and they've needed to change. So a little bit about my background. I'm a nephrologist, kidney doctor. And when I came out of training 20 years ago, I was really surprised by how unprepared I was for what life on dialysis was like. The suffering, the time constraints, the draconian diet restrictions, the hospitalizations, and just the loss that, you know, at 5 years, survival on dialysis is a coin flip. It's not an answer to kidney disease. And even transplant, which is much better, is not an answer. What we really need is to understand kidney disease at its basis and to go for a cure. The way we saw the panel on oncology this morning talk about the way they approach disease, going to the biology at the very center of it, and being able to, through precision medicine, deliver therapies to people that really work for them. We've not had anything like that in nephrology. And we mostly just control blood pressure, control your diet, prepare for dialysis. And it was really depressing as a nephrologist. And so I confess, after a few years, I said, okay, if the top causes of kidney failure are diabetes and hypertension, I've got to go back a step further and see if we can do something about this. And so I ran a hypertension clinic for 16 years, just me and a patient in a room trying to get blood pressure down. And what I didn't really realize at the time is that something was being discovered that was going to turn all of that on its ear, and that's AMKD. So somebody was smart enough, a whole bunch of scientists, to say, why on earth do African Americans have 4 times as much kidney failure as their white counterparts? You know what we do as doctors? You blame the patient. Oh, it's compliance, it's diet, it's lifestyle. And that never made any sense. 4 times as much kidney failure. And so what they did was they looked at the DNA of African Americans with very diverse kinds of kidney disease, things that really are not all that related. And there was one spot on chromosome 22 that kept lighting up. And it turns out it was a gene called APOL1. And APOL1 is a brilliant little protein. It's in all humans, and it's actually part of our immune system. APOL1 is tucked into a cholesterol molecule, which is a nice little morsel for a parasite. If you've ever heard of African sleeping sickness, that's a trypanosomal illness. And so that parasite, you have a bite from the tsetse fly and it's in your bloodstream. But APOL1 comes along hidden in its cholesterol molecule. The trypanosome eats it and it blows up. It's a beautiful bit of Trojan horse warfare. In sub-Saharan Africa, so in Western Africa, Central Africa, the trypanosomes developed resistance to APOL1. And as will happen, the protein changed over time. And it just so happened that there were 2 variants that came up that resumed the ability to kill off those trypanosomes. And so the humans got the upper hand again. And so if you had just 1 copy of one of the variants of APOL1, you were protected against trypanosomal infections, and so lived on to have a family and have a full life. So you can imagine with a gene that was that valuable, it rose in the population quite quickly. And then eventually people had 2 copies. And unfortunately, there were unintended consequences with that. Because when you have 2 copies of the variants and they get turned on by some sort of a trigger, which is usually an infection or inflammation, the same kind of warfare that you wage on those parasites happens in the kidney, and it causes kidney disease. And what's crazy about this gene, though, is, usually you think of 1 gene, 1 disease. This is a wide spectrum. Imani will tell you about her course where she had something called FSGS, which comes up in young, healthy people, really not suspecting that anything's going on, moves very quickly and can lead to kidney failure. A similar presentation happened with HIV nephropathy. I remember in the 90s when I was a fellow, we watched people's kidneys fail in a matter of months with HIV. That was AMKD. But then way on the other side of the spectrum, hypertensive kidney disease. The thing that we're told is the number 2 cause of kidney failure. You walk into a dialysis unit and have 10 African Americans on the dialysis machines who were told their kidneys failed from hypertension, half of them have AMKD. It's not hypertensive kidney disease at all. It's something that we've missed. And that's the most humbling thing about being a physician, is to realize when you've missed it. But it is an opportunity when you realize you've missed it, that maybe there's something we can do about it. And so what that comes back to the question of who has these genes and what does this mean? Now, because these genes arose in sub-Saharan Africa, only people of African ancestry carry these variants. Now, that doesn't make it a Black disease. African ancestry is very different. As you know, over 4 centuries, 12.5 million people experienced forced migration across the world, North America, South America, Europe. And so a lot of people with African ancestry don't even know that they have it. And so you can't look at someone and know that they carry these variants. You have to have a genetic test. In the United States, 13% of African Americans carry 2 copies. That's between 5 and 6 million people. Now, I'll reassure in saying that not everybody who carries 2 copies of the genes gets the disease. Again, it has to be turned on by an inflammation or infection event on the order of 1 in 5 people. But that still makes it responsible for a tremendous amount of this excess kidney failure that we see in African Americans. that we've called other things, that we've blamed the patients for. And we now have the understanding at a molecular level of what's really going on. And that opens up a lot of hope. And so that's what I'm really here today to talk about is hope.
Thank you so much. Thank you so much, Margaret. And I share that word hope, and I heard you say the word cure. I've been with the American Kidney Fund for almost 2 decades, and we never talk about cures. We talk about maintenance. We talk about trying to slow down progression. But the idea that we are looking at something that might open some doors to find some cures is so hopeful. So thank you so much for that message. And I want to turn now, because we talk about people who are potentially affected. The only way to determine if you really are is through genetic testing. And Barbara Harrison, could you talk with us about what the recommendations would be, what a person should consider with regard to whether they should have genetic testing? Also, what's the process? And what do you do if you find that somebody in your family has both of these variants in both genes?
Absolutely. So good, I think it's afternoon now. Still morning. To everyone's long day. And also happy AMKD Day to everyone. So, so to answer your question, that right now the current recommendations for genetic testing involve people who are already experiencing symptoms. So in the moment, there's no recommended testing for individuals that are asymptomatic. But if you have Western ancestry, and the recommendations specifically say recent West African ancestry or ethnicity, and you are experiencing chronic kidney disease, proteinuria, or have a family history of kidney disease, then that opens up the door to genetic testing. Now, the way that genetic testing is done physically is typically pretty non-threatening. So it's usually maybe a blood sample, but we more often now are doing saliva sample or rubbing the inside of your cheek. And so with that, we can take that to the laboratory. We can look at that area on chromosome 22, look at that APOL1 gene, and identify what variants are there. And if you have that pair of variants, which would be one from the egg and one from the sperm that made you, then you would be considered having a high risk, what we call genotype. Genotype just saying you have these 2 variants. Now, if you have someone in your family who fits that criteria, has the testing, and is identified as being high risk, well, we know that they got those genes from somewhere, right? So we would know at the very least that each of their parents carries one of those copies. Now, we understand from what Dr. Collins said, if you have one copy, you don't have an increased risk, at least that we know of, for kidney problems or kidney disease. And so for those first-degree relatives around that person who is identified as having those high-risk alleles, having those pair of high-risk alleles, those individuals certainly have a risk to carry one copy, but typically not to carry 2. Does not mean those individuals can't think about being tested. We just don't have enough information right now to merit saying that all those individuals should be tested automatically. Now, the tricky part is, though, how do we identify those individuals with 2? And how can we do it before they develop proteinuria or develop chronic kidney disease, right? Because that would be the goal. And so I think that brings us back to thinking about at what point or to what threshold do we start to offer this to more individuals? I'm really glad Dr. Collins made the point that this is not a Black gene, and that you don't know what someone's ancestry is just by looking at them. We have been socialized, we have been just made to always link what someone's ancestry is to how they look. And that's called racialized medicine. That is not generally a positive practice, right? That has gotten us into a lot of trouble over these 400 years to where we are now. And so I don't want us to fall into that same trap, which is convenient, right? It fits what we think, but we really need to fight that thought and say, no, you don't know what someone's ancestry is just by looking at them. To say that we should only offer this to individuals who identify as being Black or identify as being African American is going to be a shortfall to the whole population. Because we know that people choose those identities not just based on maybe what they think is their ancestry, but they base it on these social pressures as well, you know, that have developed again over time, particularly in our country. So it's hard to answer that question about what is kind of that magical answer of who we offer testing for and who we don't. So right now we use the guidelines that we have, but I think it presents an opportunity to think about how to broaden that, how to, again, use this information in a way that will help us prevent disease, that will help us to be in front of the issue and not wait until that issue happens. So,
thank you so much. And now we're going to go with all the questions that you've raised in your answer for us to think about our families and what we know, and to try to, you know, contact healthcare providers and go further in those discussions. Amani has actually been through this process. Amani, tell us how you're doing now, first of all, and talk with us about your journey from the beginning to where you are today.
Well, first of all, happy AMKD Day, okay? Because everyone in this room has the potential to be affected by APOL1. I'm doing good now. I'm on a medication. I'm very optimistic about it. It's lowering the level of protein in my urine. But okay, so from the beginning, it was quarantine 2020. I was 17. It was the first day of my senior year. I was experiencing stomach pain. I was swelling in my legs and my arms. It was terrible. So my mother took me to the hospital. Of course, I'm like, no, I don't want to go. I'm fine. I'm fine. Let's go. She's like, let's go. So they do the traditional urinalysis, and the ER doctor says, okay, there's protein in your urine. I'm like, duh, it's always been there. Because I've had doctors that say, you have protein in your urine, but it's because you're obese, you're not living a healthy lifestyle. And it's like, okay, overlooked. But this particular doctor said, no, we're going to do a 24-hour urinalysis and see what happens. She comes back and says, this is scary. So we go in to do the kidney biopsy, and of course you have to wait. The nephrologist from the hospital comes in and says, you know, maybe it's nephrotic syndrome, kidney disease, lupus even, all which are unfair concepts for a 17-year-old to think about. So I'm waiting. Then I go to a nephrologist at Children's Hospital, and she says, you have FSGS. And I'm like, okay, great, what is that? And she says, your glomeruli and your kidneys, which are the filters, are scarred. And I say, thanks, let's fix it. And she says, there's no fixing that. So I go on to take 3 medications, all which did not work at all. So then my nephrologist says, let's go on to do genetic testing. And she says, within 2 weeks, you have the APOL1 gene mutation. And there's a sigh of relief that I felt at the beginning, because I finally believe it's not my fault. I didn't do anything for me to hurt myself. It was going to happen anyway because it's in my genes. And then I start to feel a sense of resentment to the doctors that I went to before, because I wish I had known earlier. I wish it wasn't overlooked. So now we're here, and I'm sharing my story, and I'm proud to say that I'm surviving AMKD.
And every time I hear Amani's story, I focus on the fact that this started when she was 17, and how she has handled it. You know, she has tackled it. She is tackling it. She owns this. And so we are, if I can say, just so proud to have you as one of our ambassadors, Amani.
I appreciate that. Thank you.
I want to come back to Dr. Collins for a little bit, because there isn't a lot of guidance right now with regard to treatment. Could you talk about what is out there, and also talk about why it is so critical to have early diagnosis?
It's a wonderful question, because we are in this phase where there's more unknown than there is known. And And let me say too, when I talk about cure, that's a hope. That's not there yet. But the one thing about understanding APOL1 that's going to be important is that often there's going to be more than one thing going on when it comes to kidney disease. And we know in African Americans, the rates of kidney failure, even in people who don't have the variants, are higher. And so you have to think about blood pressure control, sugar control, weight, all of the things that we know are good for kidneys still apply. But as far as the cause of AMKD, there is no treatment yet that reverses that. Now, I will say yet is the key word because there's so much excitement about this disease. There are multiple scientists, multiple groups of people working on potential therapies for this. There's a lot of energy because this is really the first disease in nephrology where there's even been an inkling of understanding it at its base. And so hopefully in time, there will be therapies. But right now, it's a matter of doing all the things that you need to do to stay healthy. But it's interesting, they did look at people who knew about their APOL1 status and people who didn't know about it, and just what difference the awareness has. And it did make a difference in how empowered people felt about their health. Their blood pressure control was better. They were more likely to exercise and to lose weight and to do all the things that would help them stay healthy. So that's very valuable in and of itself. But of course, the other question is, how if there are therapies that come out, if there are possibilities, we have to get those through clinical trials. We have to be able to get them to the point where we know that they're safe, we know that they're effective, and then they're available. And that's not easy, as we just learned about in the panel earlier today about running clinical trials. They talked about the importance of equity in representing the population of folks in the cancer population. Here, this is a 100% minority population that we're running studies in. And so coming to a place where you address the mistrust of the past, which was sorely earned, unfortunately, this is a point where a lot of conversations need to happen about trust, about partnership, about empowerment, and about moving forward together as a community in the African American community, the Hispanic community, the medical community, working together to try to get therapies that may come out to the point where they really are of use. This is a time where time is of the essence. People every day are losing kidney function from AMKD. I personally had a patient that I sent for a clinical trial who wasn't enrolled because their kidney function was too low. And that broke my heart. I missed the window for him. And so we need to move things along quickly. And so I think that's a paradigm change for nephrology. And you may find that when you go to your doctor and talk about AMKD, talk about genetic testing in kidney failure or kidney disease, that you may get a blank stare because they're just not used to it. And we doctors, we're not very quick about things. It takes us a while to figure things out. And so you may find that you're teaching your doctor instead of the other way around.
Thank you so much. And let's continue that because early diagnosis and early treatment, working with your doctor to the extent that there are treatments for some of the other conditions is so critical. Let's talk about how genetic testing can help to improve. How does it play into guiding the treatment? And also let's talk a little bit about what are the benefits and risks of genetic testing? What are the costs of genetic testing?
Absolutely. So I think we've heard, pretty well about what these benefits could be. If you're identified as having this high-risk genotype, of having these two variants, then you face that person faces a 15 to 30% risk to develop serious kidney disease, right? End-stage kidney disease. And so armed with that information, it can help that individual make those personal lifestyle changes that might help to lessen that risk. And I want to put a pin there because I think it is important, even as we heard earlier, getting this information about your genetics hopefully drive people to be empowered, right? To see this as, okay, I have this increased risk. Let me do what else I can do to help to keep that major outcome from occurring. On the other hand, sometimes people hear that genetic risk and they see it as destiny. Okay, I have this, I found out that I have these, two genes or, two variants in this gene, and this is just what's gonna happen. So let me just go ahead and eat what I want. Let me just do what I want, because no matter what, I'm gonna have that high protein, right? And that's usually a phase that people kind of go through in their understanding of how to process this. But we know that we are more than our genes, right? And so it's important for us to, in the messaging around genetic testing and around getting this information, that we keep ourselves from thinking about this kind of genetic destiny point, right? That we see it as something that factors into our health, but understanding there are other factors as well. And so if someone is identified as having these high-risk alleles, that they are also given the information that can hopefully help them lower the risk of that, end outcome from occurring. So if you're identified as someone that perhaps genetic testing might be appropriate, seeing a genetic counselor would be a great next step. And hopefully you can get that referral. Usually it's done through a referral from a care provider. There are some individuals who seek out genetic counseling directly, but more typically it's through a referral. And then that genetic counselor will sit down, take a family history, get some information from you, as is appropriate. And so here it would be appropriate to talk about some of those lifestyle factors that are going on, as well as that family history. And then go on to explain about genetics and explain about this gene and the role of this gene in kidney disease. And so when you get that medical knowledge, but what genetic counseling also does is we also assist people in understanding how that information might impact that person. And sometimes that impact is psychological. Again, maybe there was a family member who had kidney disease, went into dialysis, and passed away. The impact of that in that family history for this individual now learning that they might also be at an increased risk for kidney disease can be pretty significant. And so being able to talk through that, being able to understand that one person's outcome doesn't have to be your outcome, can often be, again, switch it to being more empowering than seeming more like something on the negative. So discuss those kind of issues. And then there are some kind of social issues to consider as well. So there has been a history in this country, just in general, around discrimination. And there's no such thing as genetic discrimination. So we learned actually from our oncology colleagues in particular, when information around genetic testing, around breast cancer, I'll use that as an example, around breast cancer was available. And that individuals who found out that due to their genetic makeup had an increased risk for breast cancer were experiencing things like having increased premiums in their insurance, health insurance, or being dropped from their insurance, right? Or even losing their job, because in this country, employment and insurance are so closely tied. And if you're an employer for a small group of employees, and one of them has this increased risk, the health insurance for everybody in that company might be increased to help to cover the risk for this one individual person. And so because of that, it took about 13 years, but eventually we got through legislation called GINA, federal legislation, the Genetic Information Non-Discrimination Act, that now provides legal protections to not be able to use predictive genetic information against a person when it comes to things like health insurance and employment decisions around hiring, firing, promotion, health insurance decisions around where to set those premiums, who to cover. There's now legal protections against that. And that's wonderful. What there's not protections against are things like life insurance or disability insurance. And so those companies, when determining someone's risk, when doing that underwriting process, they can ask questions about genetic testing. They can ask questions about, did you have a genetic test that determines that you're at a higher risk for kidney disease? And then they can use that information to make a determination whether or not to cover that person or where to set their premiums. And so our legal protections have not gotten there yet. And so that's a serious conversation that we have with individuals when they're stepping into having genetic testing for something that's predictive in this way. And so for some, they'll pause, they'll get that life insurance and so forth in order, and then they'll come back and do the testing. For others, they take their chances and do the testing. And for everyone, obviously, that's a very personal decision. But those are the types of things that we consider. There are certain laboratories that do testing for this gene, and so the genetic counselor would help to identify those labs and facilitate getting that testing done, even identifying opportunities for free testing or what we call sponsor testing, where that testing can be done and not have to tell the insurance company. You can have that information for your medical care, although eventually if you want a physician or a healthcare provider to be able to use it, it's going to have to get into that medical record, more than likely for them to make the changes they want to make for your medical care and to provide an explanation for that. But those options are out there, and those are all things that that genetic counselors will talk about with individuals that are considering testing for something like APOL1.
Thank you so much. And I want to just repeat something I said earlier, that because of this discrimination with regard to not only genetic testing, but in the case of people, for example, who want to offer an organ, who want to give an organ to somebody who needs one. The American Kidney Fund has been fighting very vigorously around the country for living organ donor protections. We've had legislation passed in 32 states. There's a bill at the federal level. We're working toward getting more support for that bill. But all of these are really very important issues. They're just part of the landscape that we've got to pull together and got to correct in order to make sure that people really do get the best care possible, that if they need an organ, that there's a good opportunity to get one. And so with that said, I want to turn to Janice Whaley now. Janice, I know that you've been doing a lot of work around the country in terms of equity of transplants, because as many of you can probably know or guess, people of color are less likely, and Black people are less likely to be on the transplant list and less likely to receive an organ if they are on the transplant list. Could you talk with us some about the work that you've been doing and where you think it is today with regard to improving transplantation for people of color?
Thank you, and yes, thank you for this question, and good morning/afternoon to you all. I just flew in from the West Coast, so I took a red eye this morning. So AMKD is a contributing factors to the disparities we see in kidney failure, but there are also a lot of additional factors that have driven these inequities. And I want to quickly highlight and then discuss what we've been doing to improve embedded equity in organ transplantation. I want to start by talking about the inequities that exist in the organ donation process for Black Americans. Just as Laverne mentioned, I am the president and CEO of an organ procurement organization, and I've been in this field for about 30 years. And so it's been really exciting to see the opportunities that there are to increase donation in this country among Black Americans. But let's talk a little bit about what the issues are. There are multiple barriers to organ donation and transplantation for Black Americans. I also want to point out that Black Americans are more likely to be potential donors and patients on the wait list due to health disparities. We lag behind our counterparts in donation rates amongst racial and ethnic minorities, which have not changed in more than 20 years. So when you look at the increase in the amount of Black Americans or minorities in general that have donated, it's less than a 5% increase in that statistic in 20 years. And then when you look at the organ donation process itself, well, there's a lack of referral by hospitals to the OPO due to assumptions often made by the medical staff. You know, there's this perception that if you're Black, you don't donate. And that is so far from the truth. Blacks do donate. And so what happens is they use reasons such as, oh, this patient came in and they had hypertension. Well, they can't be a donor. That was probably 30 years ago. There are many, many donors that have hypertension that are able to be donors, and their organs function just perfectly. And then I want to talk a little bit about these race-based algorithms that are on the front end and the back end of the donation and transplantation process. And so on the front end, we had recently, it's recently changed, but the EGFR, it's the estimated glomerular filtration rate, was in place. And this rate hugely harmed Black Americans. We basically were made to wait longer on the wait list. And sadly, many, many Black Americans died because of this race-based algorithm, which recently has been removed. And I'm very happy that it finally happened. But we can't bring back so many Black Americans that lost their lives because of this algorithm. And then on the other side, when you become a donor, if I decide to become a donor today, there's this thing called Kidney Donor Risk Index. This index is put on in my profile as a donor. And so when doctors go to look at my organs, the viability of my kidneys versus my white counterpart that's also a donor, there's this thing that makes my kidney look less viable and desirable, thank you, than my white counterpart. So a lot of times our kidneys are not used for transplant because of this. And it could be because I have a lot of hypertension and diabetes in my family, not necessarily me, but this kidney index that they've put together does the same thing. So on the front end and the back end, there's huge disparities that need to go away. And so from that, there are a lot of kidneys that are discarded in this country. And I'm very sad and embarrassed to say this, but last year, over 8,000 kidneys were not utilized for transplantation for a multitude of reasons, but one of them is because people have the perception that our kidneys are not as good as our white counterpart kidneys. So there's a lot of medical misperceptions, cultural differences, and we have to do a better job at how we approach Black American families when it comes to donation and transplantation. On the dialysis side, I've met so many Black Americans who said nobody said that kidney transplants was an alternative for them. So we're disproportionately on on dialysis and also disproportionately on the wait list, and we don't get transplanted. And so there's a lot of awareness that needs to take place, and we can't approach every family the same. We have to find ways to meet people where they are and educate them about donation, have those critical conversations. And that is a part of the work that we have been doing as an organization. I work with the Organ Donation Consortium. It's a group of 5 OPOs that really have looked at some of the main things that we see that are barriers to donation and transplantation. So we have worked on the Hill, we've been to the White House, and we've talked about key things that are not available to us that right now that we need. And one of them is making sure that every OPO in this country has their donation rate by race. So this is where race is important and we should look at, because there is a 3.7 time difference in performance when you look at the OPOs across the country in terms of how well they do in reaching the Black community, the Hispanic community, the Asian American community. There's a huge gap. And if we're able to do better at reaching these minority groups, we're going to increase donation in this country. And so that is some of the work that I've been doing. And I want to recognize Representative Robin Kelly and Larry Bouchon, who recently co-sponsored the Organ OPT and Modernization Initiative. It's an initiative that's in place to really help us increase donation in this country. More importantly, use organs that are recovered for transplantation. And so they worked hard on this, and it is time. We've been doing this for 40 years, and it's time for us to learn new ways to do things and make sure that so many organs that I mentioned earlier are not discarded. And patients, that's 8,000 patients right there, if you think about it, that could have received a transplant. And I do know that some cases, the discard is due to medical issues that are identified later on, but that number is too big. And we know that we can do better. And so with that, thank you.
Thank you so much, Janice. We want to leave time for a few questions from the audience, but very quickly, 1 minute each. In keeping with the theme of this summit, what now? Give your 1 minute thought on what now, what's next? What do we take out of here? So, Janice, we're going to start with you and come down the line.
All right. So focus awareness campaigns, as well as repairing the past and building trust in the Black and Brown communities would be one for me. The second one is representation. It really matters. People of color must have a seat at the decision-making table. Nearly 40 years of OPOs being in existence to this day, I'm the first and only Black female CEO in the country. I don't understand why. Register to be a donor. And last but not least, I want to thank the organizers for an event that is inclusive of a discussion on how we can do better and how we can make sure that health policy is done in such a way where there's equity for all.
Thank you. Imani?
Mine is share your story. If you're suffering with AMKD, I know it may be hard, it's scary, all the bad things, but someone needs to know. When I was first diagnosed, I didn't see anybody like me. But just because you're dealt the cards that you're dealt doesn't mean that you can't win in the end. Your job is to do the most with what you have.
Thank you, Imani. Barbara?
Yeah, so I love that. What you said at the end, I may have to steal that. So similar, I think awareness. You don't know when you tell that story, who hears it and who runs with it. I have to confess, I am a genetic counselor. I'm trained in genetics, been in the field for 20 some years. Only in the past year, after meeting someone from NMQF, did I hear about this gene? And did I hear about how impactful this could be? And now I'm just like, why are we not all talking about this? And so you find, you just don't know who that word is gonna fall on and then where it's gonna spread from there. So definitely just increase awareness amongst practitioners, among the general population. You know, hopefully next year, everybody in the room will raise their hand when you ask, you know, who has heard about this condition. And then I have to say, lastly, just because I have the platform, genetic counselors are struggling right now and being recognized by CMS for our services. So we often are not in every hospital because we can't bill directly. And so we're trying to get legislation through to be recognized so that we are able to bill for our services in order to make things more accessible. If you have certain insurances, you don't have access right now. And so I have to use this platform to say that. But, you know, but first and foremost, you know, just tell those stories, talk. You don't know who you're talking to who can, you know, really spread that word.
Okay. Margaret?
So among people in the room, how many have kidney disease or a family member with kidney disease? Okay. I would say we don't have the data for this. We need to get the data. And so advocate for yourselves, advocate for your family members. Your doctors may not know what you're talking about, but anyone with potential African ancestry, with severe hypertension, with even slightly reduced kidney function, with protein in the urine should be tested for APOL1. And so talk to your doctor. The infamous thing you hear on TV all the time, talk to your doctor.
Thank you all so much. We're going to go quickly to questions, and we can take a few.
Okay.
Yes.
Hello, my name is Alta VC Wing. I'm at Genentech Roche. This was a phenomenal panel, and I have to give a shout out to Barb Harrison, who is one of the directors of the genetic counseling program at Howard University, which I attended. So thank you all. Throughout this panel, I really heard the theme of precision medicine. And it really hurts my heart that Barb, 20 plus years removed from my program, and we still have missed opportunities when it comes to genetics and genetic testing. At my job, or at Roche Genentech, I've had the opportunity to help lead an industry first, where Roche published a position on race, ethnicity, and genetic ancestry, and really making sure that we as a company take a nuanced approach to our clinical development, our research and development, and our personalized healthcare when it comes to race as a social construct, ethnicity, and genetic ancestry as a biological measure. So my question for the panel is, how can we really move to a state where ethnicity and genetic ancestry can be assets in this precision medicine era? And we don't necessarily rely on race, because we know that race can be used to harm populations, but ethnicity and genetic ancestry can actually be helpful. And it has been helpful for some time. We know that people who identify as Ashkenazi Jewish, we can instantly identify that they are at increased risk for certain genetic variants. And we actually offer special genetic tests to that population. But how can we move to a state where we could do that for other populations, where we do know that those genetic variants, those genetic associations can be extremely informative and even potentially help save lives?
Barbara, could I ask you to respond to that?
So I would say one thing is it has to start with really our research, right? Because our research is racialized. So, any study that you look at, it says, right, these Black individuals who are Black, or Black individuals have this, and this white group has this, and you're comparing those two groups, and that's not accurate. We know that that's not accurate, yet it still continues. Now we use kind of different words to make it look like we're doing something different, but we're still doing those same things. I would definitely put my weight behind really offering ancestry testing and analysis as part of that research. And then that extends into the clinical space. If nothing else, not only offering testing to certain groups based on how they look, but now basing it on biological data. And if you have this biological ancestral makeup, now that opens that door. I think in certain populations like the Ashkenazi Jewish, it's worked well because of also cultural things that surround that group, not just the biological factors within that group. Because culturally, that group tends to mate with other individuals who identify as the same religion in that case. That has manifested in itself through those generations. And just other populations aren't operating in that same way. And so we need to be more sophisticated kind of in how we try to track that and how we try to use that information. Because I agree it can be helpful, but it's also stacked behind stigma and discrimination and other things that have gone on in this society. So it may not end up looking the same as it does with like that Ashkenazi Jewish population, but we still can use it in a way that's positive.
Thank you so much.
And the last thing that I will add, going back to the theme of this conference, we have the data now what? The reality is more than 30 million individuals have undergone 23andMe testing or ancestry DNA testing. So they have that information in their hands about their ancestry. And some of them actually have that health information too. So it's an opportunity to partner with ancestry-based companies and even with consumers who, again, have that information in hand to provide more of this helpful information. So I just wanted to close with that.
Thank you. We have one more question.
And I just want to add to that. I think it also provides an opportunity for us to help clinicians find value in that ancestry information. Because I think right now you get that ancestry testing, like, yeah, oh, that's nice. So that's not really genetic testing, and so we don't have anyone to really make that bridge. And I think that would be helpful.
Thank you.
Thank you and good afternoon. Thank you for such an amazing and informative panel. My name is Kemi Oshandina. I'm the Director of Public Affairs and Patient Advocacy at Sanofi, leading our transplant therapeutic area. So this was especially informative for me, but also from a personal level, I'm a Black Nigerian American immigrant born in Nigeria. So I know 99.9% sure that my ancestry is of West African descent. And I just wanted to talk a little bit more about the testing and recommendations, if there are at this point, for that early detection. How to have these conversations with my family about potentially getting tested, but even myself currently as relatively young, should I be still going to my doctor to ask about this type of testing, or is it only when you receive that CKD diagnosis?
Dr. Collins. It's a marvelous question. And because of genetic discrimination, we have to answer that question in a different way than I would like. And at this point, if you have a chronic kidney disease diagnosis, that already runs the distance as far as the discrimination issue. And so adding a genetic test on top of it doesn't make a lot of difference. But you have an 80 to 85% chance of never manifesting kidney disease just by carrying the two alleles. And so it can be just toxic information. So at this point, without a targeted therapy that we know is preventative, that would change everything, but that's not the case at this point. I would say you should reserve testing for when you've manifested some sign of kidney disease, but now you know to look. You know, to follow the blood pressure. A lot of doctors don't check the urine for protein. Among diabetics, they're pretty good at it, but outside of diabetes, screening for proteinuria often doesn't happen. And any small decrease in kidney function, any inkling that something is going on, I wouldn't hesitate. But having the conversations with your family so you're all aware and everybody's watching everybody else and making sure that we get to the doctor. That's the thing is, particularly in the issue of social determinants of health, if you don't have access to the doctor and you can't get your urine checked, you can't get your kidney function checked, you can have the most fabulous treatments in the world and it won't make any difference, because we need to be able to get to that place where you've got somebody who's got your back in the first place. And so with your family, you've got that.
Thank you so much.
Thank you. And this is going to be our last question.
Hi, everyone. Thank you so much for an interesting panel. My name is Stephanie Trinity with Pharma. So I have a question. Is there any data on or research that's been done with Africans in Africa that are expressing this gene? Because a lot of times genes that are endemic to the population are not expressed until they're removed from those environments. So are there certain environmental factors that are unique to the US that is causing an expression of this gene in African Americans versus Africans currently living in Africa?
That's another terrific question. So as far as the prevalence of AMKD, probably 80 to 90% of patients are outside of the US. I spent 2 summers in Nigeria, right in the middle of the Igbo and Yoruba tribes who have the highest prevalence. About 25% of that population carries 2 copies of the alleles. And I didn't realize if there was kidney disease there, but there sure was a lot of hypertension that didn't make sense. And so this is what we're seeing in the US is just the tip of the iceberg, but it's the place where the studies have been done. And so all of the data that we have, a lot of it comes from the United States. But yes, the prevalence in other countries is tremendous, and studying the disease worldwide will be critical. Getting therapy out worldwide will be critical, because of course, in somewhere like Nigeria, very few people can get access to dialysis. And when they do, mortality is on the order of 85 to 95%. So again, not a life-saving therapy. So yes, having a world point of view is critically important in this disease. And if we can make a difference in it, we stand to save the world a little bit. It's a very real thing.
Thank you.
Thank you so much. Thank you. I want to just applaud our audience for being so attentive, for the great questions, and especially our panel for being so forthcoming and sharing. I also want to thank again the National Minority Equality Forum for giving us the opportunity to have this conversation, and to Vertex for your support. And I want to thank Vertex Pharmaceuticals for your support to allow us to have this day. This is AMKD Awareness Day #1. and we will continue to observe it on the last Tuesday of April of each year. And we hope that our hope will turn into reality and that there will be treatment. So we look forward to that. In keeping with the theme of the conference, I have 12 seconds. My now what? Two now whats. Go to our website, kidneyfund.org/APOL1aware. And one other one, please post on your social media, #APOL APOL1 aware. Don't forget the one. So thank you so much. And I hope you take out, if you're remembering, that AMKD is a serious cause of kidney disease and that we need to be aware of it and take steps, if appropriate, to find out if we are people who need to be concerned about it. Thank you so much.
The Booker T. Washington Award recognizes an individual or organization that has made an outstanding contribution to the promotion of wellness in emerging populations. Booker T. Washington started National Negro Health Week in 1915 to promote wellness in the Black American community. From 1921 to 1953, National Negro Health Week was a program supported by the Public Health Service. By partnering with Congress and the White House, 45 years later, the National Minority Quality Forum began National Minority Health Month in 1998 as a successor to National Negro Health Week. Today, we will honor some outstanding individuals and organizations for their commitment and leadership in ending health disparities. We'll begin with senders from the National Minority Quality Forum who will present awards to several organizations and individuals. And then we will be followed by a presentation of awards to our Booker T. Washington Award winners. There are 3 this year: the Association of Black Cardiologists, Blue Cross Blue Shield Association, and Fund 2 Foundation. And please, yes, let's give them all a round of applause. Now, I want to bring up someone who really needs no introduction in this room, especially. NMQF founder, president, and CEO, Dr. Gary Puckrin.
Good afternoon. So I started the morning off breaking tradition, and I'm going to continue in that vein, if you excuse me, for taking this liberty. I have one slide that I want to show you that picks up the conversation that we started this morning. And I realized at the end of the talk this morning, I didn't say something really important to you. And that's really, and this is in the vein of the demographic shift, that the country is shifting. And so I present this slide to you. This is looking at the age distribution by race and ethnicity. The age, this is the year 2022, and we're looking at the age group 18 to 24, 18 to 24. And what I call your attention to is that those who identify as white are 52% of the population. If we go back to those who are just 18, those who are white would be the minority. They would no longer be the majority, right? And you can see the numbers for Black and Hispanic. So why am I saying that to you, right? Because we have this conversation about D&I and why it's not relevant. But the point is, because of the demographic shift, it is important. And there is no Supreme Court that changes the demographics, right? The demographics are the demographics. And so if you are going to recruit people to medical school, if you're going to recruit people into your business, if you're going to recruit people into the military, if you're going to have elected officials, it is going to be a diverse population. That's why we have the data. That's why the data means so much. So I wanted to make that point to you, that because of the demographic shift, there's a real reason why we have to go in communities and reclaim lives that we didn't take really good care of before. So let me stop there. And you can take down the slide, thanks. And what I'm now really pleased to do is to say thank you to our sponsors. None of this is possible without the support that we get from sponsors. I'm talking about this gathering. I'm talking about the work that we do in community. And one of the things that I've come to deeply appreciate over the years, and sometimes it gets lost, one of the deepest changes in America is the change in the business community. That's where sustained change absolutely happens, right? A lot of people miss the point. It is not lost on us, right, that the business community plays a deep role in our society And we're pleased. We reach out to them and we try to find a place where we can align. We understand shareholder value, and what I often say is, we want you to make a lot of money keeping us alive. Let's not be confused. We want you to make a lot of money keeping our community alive. We are not confused about that. We think that that's a good idea. That's a real shareholder value because you get something and we get something, right? And that's the point of the conversation. And so I want to say thank you to our sponsors. So our silver sponsor is the American Kidney Fund, Dexcom, GSK, GlaxoSmithKline, for those who don't know. Our gold sponsor is Genentech. Our platinum sponsors are Amazon, Amgen, Biogen, Bristol Myers Squibb, Blue Cross Blue Shield, Centene, Gilead, Johnson & Johnson, Eli Lilly, Merck, Novo Nordisk, Pharma, Regeneron, Sanofi, Takeda, and Vertex. Please join me in saying a great thank you to all of these sponsors. Because of schedules, I'm going to jump ahead with an award. We have come to really develop a really strong relationship with Blue Cross Blue Shield Association. You heard yesterday the work that we're doing on the Data Health Alliance and the changes that we're making to make sure that we get data standardized across industry. And one of the things I constantly note is that Blue Cross Blue Shield Association wanted it for the whole industry. And that was really an important step. We take that conversation to Capitol Hill. We've taken it to the administration, and we've seen some of the changes as a result of that. We got a lot of work to do. The job is not done, but we've made really, really great strides. And then beyond the work that we've done on the data coalition, it is really the value that I hear from Blue Cross and Blue Shield, their work that they're doing in child and maternal health, but their understanding that our healthcare system has to change. It has to make great strides. And their willingness to have that conversation is so incredibly important that we have to understand, how do we reimburse for equity? We talk about reimbursing for quality, but you have to reimburse for equity as well, right? And how do we make sure that we're getting it out to community? And I'm telling you that the Blue Cross and Blue Shield Association and its members are thinking about that really hard and being driven by really one of the great executives, Sean Robinson, who's the Executive Vice President of Blue Cross Blue Shield. Thank you.
Thank you, Gary, and my new friend for helping get the spinach out of my front teeth from the salad. I owe you later. Well, I won't go too long here, other than to say how grateful we are. I am personally. I've seen some of you in this room last year. It's wonderful to be back. But really, Gary, there you are. Your personal partnership, your leadership, your commitment long before this was a top of mind issue for healthcare or for the country stands bigger than any of us in this room. You certainly taught me a great deal in the last 3 years. So it's wonderful to have had your leadership. It's hard to accept an award with Booker T. Washington's name on it because it's bigger than any company brand or any individual that could be here to accept it. So it is truly honoring and grateful. I'm grateful for it. You know, in 2020, we launched our National Health Equity Strategy as the Blues. And we did it with a very bold goal of trying to reduce maternal health disparities by 50% in 5 years. I'm sad to say we're not there. But what we did do when we launched it was we launched a long-term commitment to health equity broadly and a sustained commitment to making sure that this isn't a project where this isn't a period of time, but this is part endemic to who healthcare needs to be to serve the American people going forward. So I want to thank you for the support we've had getting to this point. And as I laughed with Gary earlier, we actually moved the federal government in the last 3 years, which is not easy to do. And data is the cornerstone of decision-making and change within the system. So to have taken the strides we have in the last 3 years through an enormous coalition of partners has been an incredible blessing. But as Gary also said, we have a very long ways to go. There's probably 100 people we could thank in this room alone. So I won't start a list that I can't finish. But I do want to say that there's really one person in our organization who deserves all of the credit for the work that we've done with the National Minority Equality Forum and so many other coalition partners, and that's Keisha Brooks Coley. Thank you. We've worked together. We were laughing in the car on the way over. We've worked together now for 3 years. And I think it was, I don't know, day 3. She walked in the room and started calling balls and strikes, if you will. It's baseball season. Give me a break. She started calling balls and strikes. And if it wasn't for her courage, her directness, her experience to help us learn how to move into this space in a meaningful, authentic way, I don't think we'd be standing here accepting this award. I don't think we'd be celebrating the progress we've made with Gary and his team and the rest of the coalition. So really, this award is as much to you as it is the Blue Cross Blue Shield Association. So thank you, Keisha. And thank you for the continued work and support as we move forward.
I just realized how short I am, I think. I should have left the heels on. Good afternoon, everyone. My name is Akia Blue. I'm the Health Communications Director here at NMQF. And I am presenting on behalf of Dr. Laura Lee Hall, who wishes that she could be here today, but she sends her regards, and I'm going to read her remarks about the SHC Award. So this year, the SHC Award goes to Dr. Chinoso Akano and from Gilead Sciences. And we have 2, and Dr. Charlie John from Walgreens. All right, so not only have these companies provided pivotal support for the Faith Health Alliance at the launch of the Advocacy Council, but these individuals have served as co-chairs of the Advocacy Council and personally partnered with our community partners, providing hands-on support for health fairs and vaccine clinics. Chinoso and Charlie have shown deep personal commitment to health equity and community engagement, providing leadership and a strong voice for equity within their organizations. Charlie has made sure that Walgreens provided education, vaccines, and vaccinators with dozens of Faith Health Alliance churches, as well as hair salons, barbershops, and community organizations. Chinoso personally attended health fairs with Faith Health Alliance churches, helping provide education about COVID. Indeed, Chinoso's work with the Faith Health Alliance was recognized as the best program by Gilead in the last year. Both Charlie and Chinoso provided valuable time in brainstorming SHC efforts as well and helped engage their colleagues and other companies. The successful growth of the Faith Health Alliance was due in no small measure to the leadership of Chinoso and Charlie. So join me in congratulating them.
Good afternoon. My name is Gretchen Wortman. I'm Vice President for Policy and Program of the National Minority Quality Forum. Excuse me, and I'm Director of our Institute for Equity in Health Policy and Practice. Thank you. The Institute is presenting 3 awards today, all extraordinary individuals who help us as we pursue our mission of assuring equity and access to the creation of new knowledge. We have metrics that we collect that enable us to compare population subsets to each other. But the equity conversation is associated with the foundation of the science that then enables us all to be healthy regardless of the disease entities that manifest in us. So we are presenting awards to Clerman Acklin III, who is the Federal Regulatory Counsel for the National LGBTQ Task Force. I'm going to read briefly for you, don't go. I'm going to read briefly for you the reason why we're sharing this award with Clerman. He is one of my most recent new colleagues, but has demonstrated himself to be extraordinarily committed to creating equity for all population cohorts and the intersectionality that enables us all to have our individuality be recognized by the system. So Clerman has been working with us through the NMQF BCBSA Data Equity Coalition, but I have no doubt at all that the qualities that he has exhibited will attend all issues with which he engages. So Clerman, thank you. Thank you. Our second award will be presented to Mr. Christopher Porter, Vice President for Government Affairs and Policy of Travere Therapeutics. Mr. Porter was selected in recognition of his commitment to equitable, high-quality care for all persons with rare kidney disease, and for his commitment to diversity and inclusiveness across the health services spectrum. Most importantly, however, what I've noticed with Mr. Porter, is his focus on the essence of an issue and his ability to continue to move forward and to ignore the noise that often attends conversations. Is Christopher here? There he is. He's got fame. My last award goes to the person I've worked with longest in this group of awardees, who we're recognizing for her really unparalleled leadership and commitment to not just collaboration, but to partnership, and to assuring and her willingness to share her knowledge and her resources to assure that we can all move forward as we find ourselves addressing a common issue. Sue Peshin is President and CEO of the Alliance for Aging Research. She is also not only unwavering in her commitment to advancing quality and equity, but I will say this, she has an ability to engage with an issue and stay above the fray. I don't know how she does it. I monitor her behavior to try to practice it, but I'm not as effective as Sue is. So Sue, thank you.
Say good afternoon. My name is Kalalai Emeru, and I'm Vice President for the Center for Health Care Information and Strategy and Services. This is Michael DeSalvo. He's a program manager, both with National Minority Quality Forum. I kind of feel like I got robbed. I should have had that regulator music. But we're pleased to present the 2024 Outstanding Organization Award to Biogen. Before I get to that, I do have to plug our center. So how many of y'all know NMQF has the data? What's the theme of this summit, by the way? We have the data, now what, right? And that's very similar to the theme for our center. We have the data, now partner with us. We're more than happy to provide our services to you. So get a hold of one of us and we'll be more than happy to share that with you. Now, this award is given in recognition to Biogen's commitment to making clinical trials more inclusive through data-driven insights and consideration of the social drivers of health. So Biogen is partnered with NMQF to collaborate on this clinical trial learning community initiative, which helps break down the barriers that we've been talking about today, which really puts up walls for minoritized and marginalized communities in medically underserved communities to participate, to learn about the opportunities to participate in clinical trials. So this has been an ongoing initiative with Biogen for over 2+ years. And so congratulations, Biogen, and please come and receive your award. Receiving this award on behalf of Biogen, we have Kate Wilson and Savine DaCosta.
Folks, I think most of you know me, Brandon Garrett with the National Minority Quality Forum. I am also glad that they didn't play Pony because we'll go back to my Cap Alpha Psi undergrad days and I might have to put on a show. So good thing we changed and slowed it down, but you know, don't look at any videos from 2000 to 2003 of me. All right. But I'm really here on a serious note to recognize Courtney Lang. So Courtney, if you actually had a chance to look at the slideshow that's presented between programs, you'll see Courtney in Summit 2024, or 2023, 2022, and on and on and on. Courtney has been working with NMQF, I think, since the very beginning. You can't tell, but Courtney, I met her 10 years ago with my first NMQF Summit. And Courtney, one thing I'd say about her that she's been a stealth leader on healthcare policy, but more importantly to me, she just gets things done. In fact, earlier today, or last night, I was working on the run-up show for today's event, and I look at my inbox. Courtney had already sent it to me. That's right. The job I had to do, Courtney had already done. And so that's why I thank Courtney for what she's done and her outstanding leadership. In fact, and then one last quick story. I was talking to somebody on our team, I won't reveal, but Courtney was moderating a panel as she's done a couple of times for us. And she's like, you know what? Courtney's what I want to be. Courtney's who I want to be and who I see myself as I continue to work in this healthcare public policy space. So without further ado, I'm going to actually, did you want to say a couple of things? She'll say something. Everybody else declined, but I'll let her say it.
Thank you so much. I appreciate that, Brandon. I am truly grateful to be here. We are all part of an ecosystem of healthcare, and that ecosystem has built community. And to the NMQF family, Dr. Gary Puckrin, I could not thank you more for your support through my entire career, Lilly, Wyeth, Pfizer, and then to launching my own health equity and justice public affairs firm. You have been definitely by my side. Gretchen Wortman, we all owe a debt of gratitude because she has been the light of policy. Thank you, Gretchen. All of the conversations, to Margot, who may not be in this room, Joanne, and to all of the staff, Adjoa and Brandon, you have been so gracious over this decade. So I remember the first NMQF Summit, and Gary, I am just more than thankful for having this to be a part of my journey, and I honor you so deeply. So thank you so much for honoring me. To my family and friends, thank you.
Our Booker T. Washington Awards to two organizations. The first one is the Association of Black Cardiologists. We have been working with the association forever. And what I'd like to say to them, and I say to all the other specialists and physicians out there, because I have a deep respect for physicians, I wouldn't want that job. I'm sorry. That's a beer. That job's a beer, particularly with the federal government breathing down your neck every 2 seconds. So I tip of the hat. That's all I can tell you. But what I say to them is, we're like the statistician at the baseball game. We don't go down on the field. We don't play baseball. You guys play baseball. We look at balls and strikes with the data. And part of this announcement today is a NMQF and the Association of Black Cardiologists have reached a deep collaboration in which we are going to be partnering going forward in community, trying to make real changes in our community as it relates to cardiometabolic health. I am excited about that. As I said, we're not cardiologists, they are, but we're agitators. We like to go have a big fight. We want to get down and work together because we have to refashion a healthcare system that has the capacity to take care of our community. That's what we want. We want our community taken care of, and we are not going to wait one more second for that, right? Not one more. And so this relationship with the association, we will do clinical trials, we'll do research, we'll do quality improvement, we'll do advocacy. We are deeply partnered with the association. So I want to thank you for that. And I want to now invite the new president, Anthony Fletcher, Dr. Anthony Fletcher, to come up and accept this award.
Thank you, Dr. Gary Puckrin. Everybody refers to him affectionately as Gary, so I guess we'll call him Gary. But I'm honored on behalf of the Association of Black Cardiologists to accept this award recognizing 50 years of service. Our organization was started in 1974 with the vision to address disparities in healthcare. So many people look like us and they die inappropriately and early from cardiovascular disease. So we certainly want to thank the National Minority Quality Forum for this award. You know, one of the bullets that hopefully we're going to gain are the data, you know, because that's what the world is working on. That's how legislation is passed. That's how issues are reviewed. So again, we thank you for this opportunity and we thank you for this award. I want to take this opportunity to invite all of you to our 50th celebration. We're going to have that in Los Angeles in September, the weekend of the 13th and 14th. We'd love for all of you to be there for that. And I close with one final thing. One of the statements of the Association of Black Cardiologists that I like is that children have the right to know their grandparents, to become grandparents themselves. We thank you very much for this award.
By the way, we invite others to be part of that collaboration between the NMQF and the Association of Black Cardiologists. So don't feel as if you got left out. No, this is an opportunity, so you can come and join us in that. The final award is to the Fund2 Foundation, and I have the great honor of introducing its executive director, who is a human rights activist, a Black Panther, so you understand what I'm talking about? Yes. An interfaith minister, and a person with a deep commitment to our young people and the programs that the foundation is doing. She's been leading that organization for 8 years, and we are starting to build our own collaboration because I'm sure we both understand our future is in our youth. And we have to give them every opportunity to succeed. And so we are excited. We have our 40 Under 40 program. They have their Restoration Retreat program, but it's all leading to the same place, which is to help us get our young people on the right path forward. So the Fund2 Foundation, for those of you who don't know about the Fund2 Foundation, they have a program called Restoration Retreat for Boys and Girls, the Cradle to Greatness, which tracks grantees as they ensure Black and Brown people move towards prosperity and happiness. They also work with companies to help them find students, and they support Black and maternal health equity. They support Black families during and after birth with a focus on the U.S. Southern communities. They have awarded over $265 million. That's a pretty serious number, right? $265 million to nearly 80 grantees across the country. And we thank you for that. In the areas of education, cultural preservation, health, music and art, social justice, career readiness, environment, and digitation. So it's really just a fabulous honor to invite its executive director, Linda Wilson, to come up and accept this award.
My goodness. Oh, so I was tall enough to get to this. Good. Thank you so much, everyone. I guess we're kind of new to you. I don't think I've ever been to one of these groups, and my team knows that I hate to come to these things, quite frankly, just because it is exactly what you all are talking about with the theme. You know, we know the data, right? Had the data. And I'm an old girl and have had the data way longer than most of you here. And it's kind of the same data. So we're so glad to be here to know that you all are working on it. And I want to congratulate my other guess you call it co-awardees, because I just came from having a nuclear stress test. So cardiologists, love you much. I think I found out I have a large heart. I need one. And I also threw down my insurance card from Blue Cross Blue Shield. So, but the Medicare one. So forgive me while I read, because I'm kind of loopy. If you had all those tests, you know what I'm talking about. So thank you so much. And if my team could just raise your hand, I love them so much because I work them hard. As you heard, I was in the Black Panther Party and we didn't have any money. And so you can get a lot done even without money. So they know they have to work. So let me read my remarks. Fund 2 Foundation was founded by Robert Frederick Smith. I don't know if anybody knows who that is, but he's the guy that paid off the student debt of the Morehouse class in 2019. Yeah, so he's the founder. Oh, Lord, y'all don't even want to know about that story, but let me put it this way. His favorite heroes is Booker T. Washington. And that's because of the innovation and rigor inspired by Booker T. Washington. Robert decided to dedicate his life to uplifting African-American communities, and he will be overjoyed that Fund 2 received such recognition, but he will be jealous that I got to receive it because I'm his aunt too. So I can't wait to rub it in. Anyway, so at Fund 2 Foundation, we understand that change starts at the individual or organizational level, but must always challenge the system stuck in stasis. We know we are all connected as a community, building a village of care, but you all are doing the work. We are not, but you all are. We are not the experts. So to support you all, we decided to convene whenever we can, those who want to collaborate. We want to amplify all your great work that's being done and educate as many people as possible on the facts as well as the nuances of having a great birth experience. As we gather here under the theme, we have the data. Now, what it reminds me of something I always say, we know the facts and we live the stats. We don't just stop at data collection, we act upon it, and I love that what Gary was saying, urgency and purpose. If we think about it with both our minds and bodies and we listen to each other, the answers are there. We ancestrally know there is a better way to live and care for each other. If we practice in small bites, we can infuse it into the culture permanently. I want to do a little commercial for a book that a man found in a little white bookstore in Mississippi, and it's called The Women Who Caught the Babies. And what we will do is get you all copies, and so that we can give it out to you. It's just beautiful, and it's a story of African-American midwives. I tell you. And Eloise Greenfield is the author of The Women Who Caught the Babies, and she wrote, somewhere in the African past, before the guns, before the shackles, before all that, there were the women that caught the babies and guided them into this world. The answers are and have been in our homes and communities with our midwives, doulas, physicians, nurses, mothers, grandmothers, and partners. Thank you again to the National Minority Equality Forum, and together, let's continue the many calls to action. Let's find where the money is that's being wasted. I heard there's like billions of dollars for Black maternal health, and we're like, where is it? We're gonna find it, we pledge. Let's ensure we transform medical education. Let's engage all parts of our families. Let's support the development and retention of Black doulas, midwives, and birth workers. Let's support dialogue that explains policy initiatives in plain language. Let's serve vulnerable pregnant people. Let's tell our stories to educate our community. Let's use AI, technology, and innovation to improve Black maternal health, and let's turn data into action. So be it.
I want to thank all of our awardees, and again, thank our sponsors who have made all of this so very, very possible. And so I'm going to turn the program back over, and thank you so very much.
That was just wonderful. Can we give another round of applause to the awardees? So, a quick story. While all of the Booker T. Washington awardees are created equal, only one has covered me since I was 8 pounds, 5 ounces, and that's Blue Cross Blue Shield. So, if you want to know how special this conference can be, I've met the last 3 presidents, last 3 vice presidents, several celebrities, A-list, B-list, C-list. I was equally as excited to meet Kim Keck from Blue Cross Blue Shield yesterday and say, thank you for covering me since I was a baby. So anyway, to all the awardees, congratulations. Thank you again to the sponsors and to all of you for participating. I have one announcement to make. I'll see some of you at the dinner. And if you're planning to attend the dinner, if you look at the screens around the hotel, you'll see your seating assignment. So check the screens to see where you're sitting. Enjoy the rest of the conference. Thank you.
Why didn't the doctor believe me? Did I say something wrong?
Do we have to experience the same pain and bias as our parents and grandparents? What if they actually gave us access to those clinical studies we learned about and those cutting-edge medicines? How many lives would that save? How much longer would we live?
What if we asked the bigger questions and really tackled the root causes of systemic inequities in healthcare? People of color still do not receive equal access to healthcare. We're determined to change this.
Good afternoon. Ooh, I appreciate that talk back. This is great. Well, welcome to our session today, The Promise of Diversity in the Healthcare Workforce. We have quite the esteemed panel, and I'm looking forward to this discussion. So I'm just going to do some brief bios, all very esteemed. So I encourage you to look at LinkedIn because I'm going to do just a small bio intro. So we have with us Deborah Grimes, Senior Vice President of Diversity, Equity, and Inclusion for Ochsner Health Systems. Deborah is an attorney with a strong background in hospital administration, having worked at UAB Hospital as the Chief Compliance Officer, serving as the first Chief Diversity Officer for UAB Health Systems. And she also serves as the first VP of Diversity, Equity, and Inclusion for Ochsner Health Systems, and she now serves as Senior Vice President. So she's accustomed to being first. Deborah in 2019 was named one of the most influential women in corporate America by Savoy magazine. We also have with us Dr. Lydia Isaac, who's Vice President of Health Equity and Policy at the National Urban League. Dr. Isaac also has a faculty appointment at Johns Hopkins Bloomberg School of Public Health in the Department of Health Policy and Management. Dr. Isaac has worked in local and state government throughout her career and in academia, where she has taught classes on community health assessment, social disparities in health. And Dr. Isaac's research interests include advancing health equity through translating research into policy, practice, and investigating the mechanisms that lead to racial and ethnic disparities. We also have with us Dr. Cameron Lee Matthews. Dr. Matthews is the Chief Health Officer for City Block Health, a transformative value-based healthcare provider integrating medical, behavioral, and social services for Medicaid and dually eligible low-income Medicare beneficiaries. She previously led transformational efforts at the Veterans Administration focused on integrating veteran-centered models of care, including the implementation of Mission Act of 2018 and the EHR modernization effort. She's an elected member of the National Academy of Medicine, where she chairs the Health Policy Fellowship and Leadership Programs Advisory Committee. And last, we have Dr. Chisaka Cunningham. Dr. Cunningham is co-founder and Chief Scientific Officer of Polaris Genomics. Dr. Cunningham is a leading voice in advocating for diversity and representation in the field of genomics. He's previously worked with the VA headquarters overseeing a large neurodegenerative disease research program and also served as a subject matter expert for the VA's genomic medicine implementation program. Motivated by the timely need for advancement in precision medicine while at the VA, Dr. Cunningham is dedicated to improving people's lives through the power of genomics. Please join me in welcoming our panelists. So as the title of the program, The Promise of the Diversity in the Healthcare Workforce. As I realized I didn't introduce myself. I'm sorry. Why don't we start there? I'm Alethea Jackson. I'm Senior Vice President for ESG and Chief DI Officer for Walgreens Boots Alliance, the parent company of Walgreens. So I'm really excited about the discussion we're going to have. I think we're all very passionate about diversity in the healthcare workforce when we think about improving health disparities, growing health equity, and improving outcomes in communities of color. We look at one of the important things that we can do is improve the diversity in our workforce, and it's so critically important. It's not a nice to do, it's a must have, and it relates to actual data, scientific data, when we think about outcomes. And so that's where we want to kind of center the discussion in today as we have all of our panelists. I'll start by saying that research shows that diverse representation in the healthcare workforce improves patients' access to care, their perception of the care that they receive, their health outcomes, and especially patients of color. I think we can all think about relatives or people we know who are somewhat questioning, when they receive either that diagnosis or that care, and really look for that voice of, okay, who can I trust to give me this information? Because trust is also key when we think about the healthcare system and people's healthcare needs. And as we look at the importance of that, data also tells us that less than 3% of physicians are Black or African American, and only 1% identify as American Indian, Alaskan Native, Native Hawaiian, or Pacific Islander. And so we still have a lot of work to do when we think about that. We also look at the maternal health crisis, and less than 6% of midwives identify as Black, although we have a Black maternal health crisis. And so as we walk into this discussion, I'd like to ask each of the panelists, why is it important to have diversity in the healthcare workforce? And I'm going to start with Dr. Cunningham.
Well, I think, this is a challenge for our entire society. It's not just for the Black and brown people, it's all, because our goal as researchers and clinicians is to help everybody. So I always say, in order for everybody to be serviced, everybody needs to be present. And right now in our research infrastructure, especially, we're not. You mentioned the clinician piece. If you're a PhD molecular biologist that does translational research and you're African American, that's like 0.3%. So I'm kind of in the 0.3% there. And I think that that's something that we really need to work to change, because as our population see ourselves being represented, our communities represented, we're more likely to trust and therefore participate. So it's a code that we haven't cracked yet. And I don't really know all of the ingredients other than creating more opportunities, particularly for young people, to get engaged early, and creating mentors and role models all throughout the chain. So not just when you're in school, but once you're past school and you're trying to get that first job, and you're trying to grow in your career, having this sort of lifelong, career-long mentoring process for minorities, underrepresented minorities, that works well as well. And we haven't done that yet, but I think that's something that we can achieve to help us start to solve this problem.
Thank you. And Dr. Matthews?
Yeah, I'm a very proud family physician. And in primary care, not only does our healthcare system not recognize the importance of the primary care relationship and the continuity that is actually a solution when we're talking about health equity, there's a significant dearth of Black and brown faces in primary care as well, in every field, and might as well not isolate them. But when we're talking about a solution that can really describe prevention, that can really empower patients in their own healthcare, and to be with them in that lifelong relationship, the fact that we have difficulties in our workforce of the primary care workforce overall is a problem. We have an amazing behavioral insights team at City Block, where we're providing, again, primary care services for Medicaid populations across multiple states. And one of the first insights that we gleaned from our patients, just asking them outright, is that they wanted care teams that look like them. This is not just data. The data is important, but it's also anecdotal directly from the patients that we're serving, that look like them, that live and work and pray where they do. This is something that we've put a lot of emphasis on, and thankfully, we consider ourselves a very anti-racist organization, so we put purposeful intent behind this. Most organizations do not. It is maybe a line in their mission statement, or it's a minimal financial focus that a lot of healthcare organizations make. And I think from the primary care practice standpoint, the fact that we've been able to direct this, of course, with the limitations that everyone has, there's not a lot of us out there. I think at least we're a good example of how we can be intentional about it, being that we have the data that our patients are asking for this.
Thank you. Deborah, anything to add there?
Yeah, the only thing I would add is ditto to all of the panelists and what you've said, but I do think data is critically important, and you have to personalize the data. And one of the things we've done at Ochsner Health is to really understand the health of our state and tie it to, most people live in the area, they work there, they love it, and New Orleanians really love it. And so we tied all of our efforts to, we want to make the state healthier. And we're all one crisis away. The pandemic showed us that, of a lot of people dying because organizations are not taking it seriously. So you have to be intentional, you have to use data, and you have to personalize it so that you're not talking about other people, or it's not people that you don't know, it's people in the communities that you have the privilege to serve.
Love that. And one of the things you highlight is how local it is, right? And that, healthcare is this very personal and very localized thing. And so making that as close to the individual and to the patient is possible. And so that they can see themselves and sort of understand and know that they are being seen, more importantly. So with that, I would ask Dr. Isaacs, what are some of the barriers that we're seeing to have a more diverse healthcare workforce?
Wow, you're asking me to answer for the world, but I think it's some of the ones that we've talked about previously. I think there's definitely, whether you want to call it an education barrier, there's a I was the previous panel or 2 panels ago, somebody was saying representation matters. People not seeing themselves in the workforce, and it may sound cliche, but it's I'm going to tell you personal life. I watched this show called Critifixers, and it's about these 2 Black vets in Georgia. And there's a commercial where there's a little boy who says, the vet asked him, well, what do you want to be when he grows up? And he said, I want to be you. And so because he saw that Black vet in his community, then he was like, oh, I can take care of animals. I can do that also. Right. So I think representation matters. I think having the pipeline, I think like Shaka said, about understanding what it takes for a young student to get through that pipeline and supporting them through that is really important. But we also have to think about populations that we don't normally think about. So our reentry folks, our folks who are coming from the criminal justice system, how do we prepare them and support them in entering fields in which they could actually be a really great resource, peer specialists, helping with addiction services, with behavioral help, supporting them in using their experience to help people in their community. So I think the barriers are all the ones that we said. It's education, it's money, it's space, it's time. There's not enough mentors to mentor all the people that we would need to, but we have to make that space. And we also have to use the full workforce. We have to make sure that, and I hope this is not controversial, not everybody's going to be Shaka, but somebody could work in his lab, right? And so we have to think about the whole spectrum of the workforce and not just the person that we see as the highlight, but all the other supporting actors that's important to see. I always tell the story about going to a hospital and the facility staff was somebody that my parents knew, and they were able to navigate my dad who can't see through the hospital. That's an important person in that healthcare workforce that people don't even see as a healthcare worker.
So why did you act like you weren't ready to answer that question? You were ready to answer. You had all the answers, right? So, but absolutely, and you touch on something that's so important, even from our perspective. At Walgreens, we have pharmacy techs. We have the pharmacist, and then we have the techs. The techs are a valued part of our ecosystem, right? And they support the pharmacists. And when we looked at the pandemic, upskilling our techs, and so our techs were able to give vaccines. And so, looking at everyone, to your point, within the system. Where are those points of entry? How can we get people into the workforce in all of the different roles are so critically important. So absolutely. Deborah, question for you. So Ochsner sits at an interesting intersection because you are both a large health system, so provider of care, but then also a large employer of a healthcare workforce. And know you have efforts around increasing diversity in the workforce. How have you embedded those efforts both in your values, but in your business strategy as a company or as an organization?
Yeah, that's a great question. I think it's really creating an ecosystem where diversity is valued as a business strategy in terms of being data-driven, outcomes-driven, and mission-driven. Because people want to work at a place that is more about purpose. But at the same time, we do know that healthcare is a business, right? And I think one of the things the pandemic taught us is that the workforce is critically important because you can't deliver care without people. And people have options now, and they're not going to stay at a place where they don't see value in themselves, that they're not respected. And that's one of the things that Ochsner Health prepared for before the pandemic. And that's why we have retention rates that are higher than they've ever been. And we have engagement rates that are higher than they've ever been. And our turnover is very low. It's because when you look at the numbers, people who are engaged in employee resource groups, they have more retention, they have higher engagement. And we show those numbers. And so that is a business strategy. When you drill down into why people work where they work, it's not about the benefits. It's not about having a job. They want to see, what is your organization doing in the community? What are you committing to? What do you have a higher purpose than just making money? And so we have to tell those stories, and we have to highlight the things that we're doing in a way that's very authentic and respectful.
That's great. The purpose piece is so key, and you lift up during the pandemic, right? I mean, healthcare workers continue to show up. They continue to show up. It could have not done that, right? But it was, again, very purpose-driven in the way that, again, we want to help. We're here to help. This is, what we were trained to do. And then keeping team members engaged as well. And especially, again, as we think about the diverse workforce, ensuring that you mentioned business resource groups, that they also feel like they have a space. So how critically important that is. So Dr. Matthews, and you've touched on this some, we know there are some non-clinical factors that impact adherence and health outcomes. And I loved to hear the bringing in the behavioral piece because people walk in as their whole selves, not just with their condition, but with all the other things that are happening in their lives. And so you're trying to treat the condition, but have to touch those other pieces often, I would imagine. So can you talk a bit about the relationship between diversity in the healthcare workforce and improving health outcomes and adherence?
Definitely. And the data is clear around patient communication, engagement, just experience overall, including something as basic as Press Ganey scores. There's significant difference shown when there is racial and ethnic concordance between the provider and the patient. And it really is tantamount to how our patients trust us. That's one thing that I am really proud of in City Block, that we've been able to focus, not just putting it on the backs of the care teams, but focus strategically on how to earn our patients' trust and how to engage with them. And not make assumptions that they're going to trust us just because we have this medical knowledge, but that because we're a part of their communities, that we are standing by their side throughout their spectrum of engagement with the healthcare system. And we're recognizing that at times they're even traumatized by the healthcare system. And so we build this into everything that we do, and it really does improve outcomes. We're seeing higher rates of just communication, of outreach, of preventive screenings, of chronic disease management, self-management. That's really a tool of empowerment. And it really follows, it tracks the data quite well that we continue to see. I mean, just even did a quick search, even in 2024 alone, the number of studies that are coming out showing the importance of racial concordance, racial and ethnic, and gender. And actually it's beyond just race and ethnicity, I apologize, that concordance is necessary to improve outcomes because of the difficulty within our healthcare system, and that we assume that trust is going to be there at the onset. But of course we saw during the pandemic the obvious need for us to address that. And we see that regularly in public health circles, but yet we as an industry are not doing enough to combat that. So if one thing that we can do is to really use our workforce, what we're trained to do to earn that trust, I think the diversity of the workforce is just one way to approach that. I think in regards to particularly a special patient population that we take care of, even within the Medicaid population, of course, there's kind of cohorts that need additional attention. The one in particular that we're quite proud that we've had improved outcomes around are persons with serious mental illness. Our inability to help this population. I mean, even for those of you who are from DC and you drive the streets, you see the tents, you know who's actually living there, and we know what this city, this public health system is not providing to these people. We're very proud to be offering a wonderful advanced behavioral health program where we're getting them on outpatient-based treatment and preventing admissions and, again, earning their trust. And that's through a workforce that is meeting them where they are and that understands who they are, how they've been traumatized, and how their mental health impacts their physical health and vice versa. And so we're doing it in an integrated way. So it's also a difference in how we allow our workforce to engage. We're not just referring them out to psychiatry and as a primary care practice, just not really owning the outcomes there. We're actually looking at it holistically as these whole people deserve. So very proud that our workforce is what's empowering, allowing us to have the patients empower themselves, actually.
Mm-hmm. And Dr. Cunningham, can you talk about, and just going to continue to pull that thread on trust and the importance of that when you think about genomics and engaging diverse communities?
Yeah, it's of paramount importance. Trust is really important to establish whenever you're asking one group to interact with another, really. And particularly with this research. And I say about genomics is about as personal as you can get. Right? It's literally your DNA that makes you you. That's the most personal information you can have. So to ask someone to share that with the world or with your research study without really letting them know why or building a trust rapport is kind of, a bit of medical malpractice in my opinion. Like, you should really at least take the time to get to know those communities that you're asking to engage with and give them the information as to why they should participate. And I spend a fair amount of my quote unquote corporate time doing that, reaching out to communities. I actually have a nonprofit that I work with called the Faith-Based Genetic Research Institute. And our mission is to work with minority churches to get the message out about the importance of genomics and health and educate populations right where they are in churches. There are a lot of churches here in the DC area that have health ministries, health and wellness ministries. So we'll go and partner with those ministries just to talk about genetics and health. And many times we're the first people that have ever done that in that environment. But it has had a tremendous impact, as I've seen, because once you meet people where they are and start telling them the benefits and also addressing their real concerns, then you build that trust rapport that helps them be encouraged to participate. Mm-hmm. And through FBGRI, we do have an outreach program here in the DMV. We're actually part of a year-long outreach program for the NIH All of Us program to try to get more people of color here in the DC area to participate in this free, publicly available genomic study. And I'm hoping that happens because, as I say to many of my minority colleagues and my African-American friends, if we're not present, we'll never benefit. I'll use the biblical scripture that I love the most in the book of Hosea. My people perish for lack of knowledge. And I say this knowledge of our genetics, African and other minority genetics, is knowledge we can't afford to lack as a community. And so I'm hoping that more of us participate so that we can actually benefit. Now, I have colleagues who actually do research in this regard. I have a colleague who does breast cancer genetic research. And she's actually shown that the currently available breast cancer BRCA1 tests don't apply 40% of the time to African-American women. African-American women have a whole different set of BRCA mutations that are just now being discovered. And this wasn't part of the original test because the population used to develop it was 96% Caucasian. Right? So when you think about that, if we're doing that for all of our genetic diagnostics, we are missing a big swath of the population. And that's the reason writ large we all have to participate. So that trust factor, though, is so important. And so we all, as providers, as researchers, need to do everything we can to help establish rapport with the communities that we need to participate so we can help them benefit.
And I want to add that it's not only about our participation, but it's also when you create a diverse workforce, the questions that are being asked are different,
very good.
right? So his friend who's a researcher said, Black women die more often of breast cancer because they're diagnosed later, but there's also something else going on. And so her looking into that data is what made her find that the BRCA gene is not the same, particularly in African Americans. So it's a diversity of opinions, it's a diversity of questions, it's a diversity of exploration that actually helps us all. Right? That's why we value experience when we talk about older adults in this world, because they've gone through a lot, right? And so they're able to inform and ask questions that, let's be honest, the youngins can't ask because they didn't do it. There's nothing wrong with that because the youngins have a different set of questions and skills that you're just like, oh, okay, I see you, right? And so, but that's important that like our diversity is, and I love that you said, Dr. Matthews, it's not just African American or ethnic. It's also age. It's also gender. It's also religion. It's also, SOGI, sexual orientation is important because the experiences you bring changes the questions you ask, and that's what's important.
I'll piggyback on that. Exactly, we need to ask the right questions, but there's also been shown that the diversity of the pipeline of the our colleagues within training, we're actually also exposing our colleagues to broader experiences. Their training is more enriched, and therefore those questions are being asked more so in the classroom. We're challenging what we're being taught, and the entire classroom setting is benefiting from learning about different cultures when the workforce is diverse, even within the education pathways. Because we know we're never, unfortunately, going to diversify the workforce enough in every setting, we need to rely on the broader workforce to be able to take care of our communities. And the diversity within our training is just as necessary as the actual practitioners, that there's a benefit within education as well.
Absolutely. Dr. Isaac, can you talk about some of the work that the NUL is doing around increasing diversity in the workforce, healthcare workforce?
So one of the things the National Urban League we have, and I will say, because I would be remiss if I didn't say my colleague, Tracy Scott, who's the Vice President for Workforce, is more of an expert on this, but I'm gonna do my best. I think what we've really been trying to do is connect people with opportunity. So at the National Urban League, we have several pre-apprenticeship programs in lots of different fields, including energy, and health. Some of our affiliates, so we have 92 affiliates across the country in 36 states and the district, focus on connecting our clients to services and jobs, particularly the reentry folks. We do actually a lot of upskilling for seniors in tech, so helping them understand and work with tech so that they could do some healthcare jobs and other folks. We have some of our affiliates who are working with community colleges to try to help that pipeline. So you start with high school. So our Project Ready, which is our career and college readiness program, starts to work with community colleges, with different organizations to see if we can start putting kids in the pipeline. So we have a huge STEAM, science, technology, engineering, arts, and math, I got it right this time, they're gonna be proud of me, program that is working with different affiliates across the country in different industries. So whether it's if a town has a big pharmaceutical town, we try to connect the kids with with that organization to see if we can find them internships or have mentors come in and talk to them. So it's really about making the opportunities, showing the opportunities, connecting folks to the right opportunities that then increases diversity in different areas. And so, we were in just Chattanooga, and one of our affiliates was telling us about how they started a phlebotomy program to start to teach people not to be scared of needles, right? That you can do this work too, but then it also becomes a cascade. If you become into the healthcare workforce, then, maybe I want to become a CNA. Oh, maybe I want to become a nurse, or maybe I want to become a tech. Or, this is really interesting. I didn't know what these radiology stuff does. And then you start burgeoning that interest, and then people start looking for those opportunities.
That's great. Deborah, I know Ochsner's doing a lot of work in this space. My question is, how will you measure success of the work? Is it on improved adherence? Is it on outcomes? Is it on the number in the workforce? What does success look like around these efforts?
I think for us, success is multifactorial. So I do think measurement is important, and representation is important, and goal setting is important, but also benefits, it transcends all of that. And to be transformational, we do have to look at the numbers. We do have to recruit, we do have to hire. But then there's some other tangible things that I think we also need to connect and monitor, like clinical outcomes. I think we do need to address what do our outcomes look like before having the diversity initiatives and after. And I think you will see a connection that a lot of your metrics will improve when you start to hire more diverse individuals. We also measure things like engagement. Does it make a difference from a demographic perspective? And I think you'll see it does. We also link things like culture, because we know now there are books being written about it. Culture actually does matter. And you will not be able to get the strategy or be able to implement the strategy if you don't have the right culture. And culture starts with trust. And if you do not have representation, trust is going to be an issue. If you do not have a leadership team that reflects the community that you're serving, that reflects the diversity in your workforce. Because when you measure all diversity, most of our organizations are going to be pretty diverse. The diversity starts to diminish when you go up the ladder, when you start getting into the C-suite. So what happens then? The trust also decreases, because strategy comes from the top, and then all of the employees are looking around and they see limited representation, and they start to question the strategy. So there's other intangible things, other real things that we need to start connecting the dots to. And I think that's what we're exploring now. It's not, we will always have to measure representation. I'm not saying we don't have to do that, but we also have to measure other things, and we have to be very transparent, and we have to communicate in the boardrooms. We have to communicate. If you're in the C-suite, you have to influence what they're thinking and how they're thinking about it. In the communities, you need to tell people what you're doing, because a lot of times you do great things and you're doing all this work, but people don't know about it. Your employee base may not know about it. So it's really being comprehensive and being intentional really does matter.
That's great. What are, as you think about the work, what's the value of partnerships, and what are some partnerships or types of partnerships that you've seen in this space that have been particularly effective? And I'll start with you, Dr. Matthews.
Well, stepping away from my day job, my passion project called the Tour for Diversity in Medicine, we've been providing pipeline programming for high school, college, and now medical students for some 10 years. Our partnerships are quite broad as far as throughout academia, the accrediting bodies, AAMC, ACOM, ADIA for dentistry, our pharmacy colleagues that are in the room. Those partnerships are critical because we have a special skill set. We have a special expertise as a group of mentors, as a group of docs and dentists and pharmacists reaching out to students around the country, but we don't have all of the information. We can't be everything to every student that we reach. So the partnerships that we create are for information, for visibility, for the transparency within a local community when we partner with local organizations. I think it's the recognition that as you build the pipeline, as you think about diversity, there's an ecosystem in which these students find themselves. And so therefore you need to consume that ecosystem in your outreach to them. I think in the workplace, it's equally as true. We do a fair amount of social service provision. We're treating Medicaid populations. There's absolutely no way that I can do so without having local and national community-based organization partnerships that can actually help us provide those groceries, provide transportation, assist with housing, assist with employment and child support and broadband access. We do all of this. And in order to make sure that our workforce isn't feeling burnt out. I think that's the other thing. The minority tax is so real as we are attempting to diversify. Most of the need to mentor students coming up in the pipeline sits on us. Most of the need to reach out to those populations that need us most sits on us. So you need those partnerships to help defray a lot of the responsibility that we proudly have on our shoulders, but oftentimes we need to put down. So the partnerships, I think, are there to help assist as we're diversifying. And I mean, it's rampant throughout healthcare, making sure that we're I'll say working to the top of our license, but our license is also, not just about our skill set, but also our capabilities as individuals through our identity. So if I'm actually, as a Black physician helping a very troubled and complex set of patients, my panels, I need some help in doing that. I can't be expected to take this on myself. And our fields are often so individualized. We pride ourselves to do things on our own and come up with solutions and the like. And I think that's the problem in healthcare as a whole. So the partnership creation as an organization is so critical to sustain the diversity that we're also putting all this energy into building.
And I would piggyback a little bit on that, again, being in a field that there's not a lot of minorities in, again, in molecular biology, genetics research, there's very few. It's not because people aren't smart. It's because people aren't getting these opportunities to actually be mentored through the pipeline. Mm-hmm. And for me, for my entire career, I've maybe had one Black mentor, and every other one has been either a Caucasian male of some extraction, whether it's Jewish or Midwestern or whatever. Now, I'm of one, I'm not, you say anti-racist, I give everybody a chance, right? If you want to mentor me, thank you. But I think what will be very most impactful for our the next generation coming up is that identification, where I work with a program here in the DC area called Future Kings of STEM. And we teach African-American and Latino boys how to get into careers in STEM, particularly science. And we start in the 6th grade, right? And I've had a cohort of boys that have been with me since they were 6th graders. Some of them are starting to graduate now. I've got a junior that's at Yale University on a full ride on Yale. I've got another junior at Johns Hopkins. And these were kids that when they came to me in 6th grade, they said, these kids are at risk. They might not be able to go to community college, okay? But when we expose them to STEM, mentor them throughout the year, and care for them and create this loving community, they become excellent. Okay, and it's not so that the talent and potential is in our community, but we have to devote the resources to mentor it. Now, you mentioned that burden. It's a tremendous burden. I'm running from soccer practice with my 2 sons to go do my STEM program every other Saturday, right? But that's my passion and that's my give back to the community, and I would have it no other way. Because if I don't do it, what other Black molecular biologists in this area is going to do it? Okay, keeping it real, right? So that's how we create more. It's going to take time. That's the long, pole in the tent. It's going to take time, but we got to invest in that level and invest at the early career faculty level. So I find myself not only mentoring kids as early as 6th grade, but also I get called by my colleagues from other predominantly white institutions where they might have this young Black man who's a postdoc who's really struggling. Can you talk to him and mentor him and help him stay with the career? That's also part of the give back. That's what we have to do. And I wanted to kind of piggyback back on that C-suite remark, because that really hit me home. When I think about my journey in my career, in order for me to get into a C-suite at the age that I did, I had to create my own company, right? So it wasn't that I wasn't talented or didn't have the ability to do it, because clearly, I have a company and it's doing pretty decent. But the idea of getting the opportunity at an earlier time in your career and having a mentor that really helped you rise through, let's say, a large corporation, those are the opportunities that are rare that we need to create more of.
And Dr. Isaac?
So yeah, I mean, I'm piggybacking on everybody said. It's not only a mentor, it's a champion, right? That there, people use this difference between a mentor and a champion. A champion is somebody who can take you through that process, who has in so many words, the power or the influence in the organization to get you to that next level. So that's a really important thing. And I was just thinking about Dr. Matthews and the tax, about how, it becomes a lot of work, but work that is actually very rewarding, but it is a lot of work. When I was a professor, my colleagues used to joke because there was always a line outside my door because every Black student came to see me because I was the only Black professor. So every office hours, there was people, they were sitting outside my door waiting to speak to me, and all my colleagues were leaving, and I'm sitting there 6, 7 o'clock because I'm going to talk to every student, right? But then what happens to me at 7 o'clock, just leaving, I still haven't graded papers, I still haven't made a lesson plan. So that's the academic kind of pipeline. I think the other thing for us to think about with partnerships is this idea of what you just said about the top of the license, that like everybody has a role in the healthcare system, and I'm going to try to be the most PC way of saying this. And some people need to stay in their lane.
There we go.
And I'm going to talk. I'm a nonprofit. I'm a community-based person. There are some community-based organizations that do this work better than healthcare does, and we should let them do it. And I say that because we all talked on this panel about meeting people where they are. The people who are on the ground know how to meet people where they are the best. Right? And so, me at the National Urban League, our affiliates are on the ground. During the COVID crisis, they were the ones that were making pop-up clinics. They were the ones that were opening their offices. They were the ones that were providing food. They were the ones that were finding PPE. They're also the ones who knew where people were who were most in need, and they found them and they got them the resources they needed. And so I think that's really important for us to think about who is the best conduit for these kind of resources, and that supporting those conduits is actually a really important part of the function, instead of deciding that I want to do the functions. And I think, one of those is community health workers in our communities are a critical resource that, one, we don't fund well, and two, we don't support in the way they need to. But they know, we had community workers, health workers, they knew where to find. It was like, Ms. Johnson, I know she's gonna need this. I'm gonna go find it. I'm gonna drop one off to her, because they're in the community. They know who's most at need, and they know how to access, and people trust them. And the through line throughout this whole conversation has been trust. And that's a really important, trusting the community to take care of the community, but supporting those communities and being able to support their other community members.
I love that. And I love the part about each of us have the role to play, right? We don't have to reinvent the wheel. We at our company believe in strong partnerships. And during the pandemic, that's one of the things we always partnered with community-based organizations. And they'd be able to tell you, come to the Flower Mart. Because if you're in LA, do the Flower Mart, because it's going to catch people in between going to work. You'll catch them as they're going or as they're coming, and having those, again, community-based organizations to help navigate those who are in the community all the time, and who, again, know where the people are and know where to find them. And there is that appropriate way to partner. There's enough work to go around. There's enough to be done. We can all do it in our own, sort of, to your point, our own lanes, but doing it together will help us go further, right? Further, faster, and it'll be sustainable. Because that's the thing also, you need to continue to show up as you come into community. So Deborah, I'd love to hear from you on that question as well, on the value of partnerships.
It's invaluable. It's unbelievable, the value of partnership, especially when you're thinking in terms of DE&I. And I think the other panelists made it clear, it's personal too. So you have to have a personal commitment of how are you going to use your power to influence and partner and sponsor. So we all need to think about our own strategy and personalize it. And then from an organizational perspective, I think you can partner in so many ways. A couple of examples that we're doing is that we recognize that Louisiana has a terrible workforce shortage when it comes to people being prepared to enter into healthcare. There are lots of reasons. You can look at anything based off of Katrina to figure that out. It's still happening right now. And one of the things we wanted to do is we went to local high school counselors and we said, we want to have a program for juniors and seniors who do not have any plans to go to college, because that was the workforce that we needed to engage in healthcare. And we started a bridge program where we worked with these juniors and seniors to say, what is your end goal? What would you like to do? And we introduced them into, okay, if you don't want to be a nurse, by the time you, and you don't want to go to college, you don't think you want to go right now, then why not be a certified nursing assistant? And we will hire you immediately after high school. And because we had a shortage of MAs, we needed medical assistants. And then there was a subset of those that said, no, I don't think I want to be a registered nurse, but I may could do an LPN. So we started them in the LPN program. And when they graduated from high school, they could immediately have a job. No, they didn't have to pay for anything. They didn't have any baggage. And then we said, okay, if you like doing that, we have this program that you could start as a CNA, work for a CNA a year, then go be an LPN, work for an LPN for a year. And guess what? We want you to be a nurse. And we're going to pay for all of that. So we have to meet people. That's the power of partnership. And then we figured out, you know what? High school is too late. We need to start partnering with elementary students with a STEM program. It's called STEM NOLA. And so guess what? We created a school. We have a school and right at like 5 minutes from our corporate office and it's middle schools, and it's all centered around STEM NOLA. And then we said, you know what? We're going to carve out some slots for this charter school for our own employees to be able to send their students to. And it's not employees that could go anywhere. It's environmental services. It's those employees that could never get into the charter school. It's partnering with our local urban league, because you're right, you do it better than we do. And we do health fairs, and we partner with them in so many ways, because you have to humble yourself to say, just because you're the largest employer in your state doesn't mean you have all the answers. But you do have some resources, and it's important how you utilize those resources. You need to influence at the governmental level. We're in DC, so we have to talk about government. You need to develop those relationships, because government plays a part in all of this, and it's about relationships. So partnerships matters in so many ways, but it starts with really humbling and realizing you don't have all the answers.
Great. You mentioned the government. Actually, the Senate Health Committee is having a hearing this week on diversity in the healthcare workforce. And so absolutely coming at it from every angle to try and move the needle. So we have these discussions, and I always like to end with a what's next and what's the call to action, as we have all of these brilliant people in the audience who are working in this space in their very own way. What are some of the things we can each do to help advance diversity in the healthcare workforce? I'll open that up. Okay.
I'll start going on the end. So I like to say, that I don't like to say, I think it, think globally, act locally, right? So I would say each one of us think about what our core skill sets are and find some minority children to help develop those core skill sets in, okay? Impart upon them why you do what you do and why you're passionate about them, so that they can view it as an option. And therefore you will naturally be a role model for them. So I think that's the local piece. And then the globally, I think, is being mindful of this in every environment that you're in. If you're in an environment where there's an extreme lack of diversity, which are many of our environments, to start thinking about how you can either as an advocate or as a member of the community that's underrepresented, help change that, right? And really be part of some action items to do it. Again, I don't think we figured it out yet, and so that means there's room for new ideas. But the things that are working in communities, double down, support those. If you see these small programs that are producing great results, then let's figure out how we can expand and scale those together through the organizations that we work in. So that would sort of be my advice. Act locally in your community, be an influence to the underrepresented minorities in your community, and then think globally. How can you really impact this problem writ large through your organizations?
You stole mine.
Sorry.
So I will add on top of that. I think, Deborah, what you just described just blew my mind of the charter school that was created, the different programming. I think each of our organizations has some way to expose local students to opportunities. How do you create that? How do you open that door? How do you create that opportunity so that students see the full breadth of their potential, honestly, and even meet people, see people, and touch people and ask them questions who are in fields? I think they have very limited exposure. Oftentimes to healthcare, it's through TV. Well, let me take that back. For social media now, for this generation, it is social media now. But there's a very specific voice that is there. You're not hearing from the CNAs. You're not hearing from the broader workforce that we know is so critical to our teams. So creating exposure opportunities is, I think, the biggest bang for our buck, to be honest, if we're really thinking about my favorite concept of stepping out of the insanity, right? It's that Albert Einstein's definition of insanity is expecting a different result, but you're still actually doing the same exact thing. Step outside of your comfort zone and create that opportunity so that students can be exposed and we can start that pipeline as early as possible. But I'm doing the same thing for medical students. It has to be exposure across the entire pipeline. What is so frustrating for me is that medical schools still give a very narrow perspective of what it is to be a primary care physician, different practice settings and the like. I think, I hate to say this, as important as academia it is, I think the way we train, particularly physicians, does us a disservice, particularly when we're talking about where the diverse workforce needs to go. So I think that exposure opportunity needs to be throughout the pipeline for faculty, for every type of professional. But that's my rec.
She stole my one, but that's okay, because I'm gonna go on it too, because I think, as a child of a Caribbean, there's like three things. You could be an engineer, teacher, or doctor, right? And so it's one of the big things is showing that there's much more to this field than just the clinical parts. Nuclear medicine, those who have to be the technology, who do the X-rays, radiology, like all those things for people who even love science but don't want to be a physician. There's a role for that. There's a role for the mathematician. There's a role for the folks who are interested in robotics, right? And so really sparking AI, exactly, sparking students' kind of mind on that is really important. And then I also want to, the second thing, so I piggy off of that, is to piggy off of what Deborah said, is policy, right? We also have to have the regulations, the laws, the programs in place to support these things, right? If we want to grow physicians, then we have to think about the number of medical schools we have. I know I'm opening a can of worms, and we don't have to open that can of worms, but I think it's important for us to think about how we train people and where they can go, because if you have, we don't have 10, but if you only have 10 medical schools, then they can only support the amount of doctors that go to those 10 medical schools, or dental schools, or nursing schools, or whatever. And so I think we also have to think about the policies and the structures around how we train all sorts of people, and how do we get people into those training pipelines. And that's only done through policy action. And so we really, there's small things like that can be done, maybe not small, but actions that people don't even think about. And I'm picking on medical school because it's the only one I can think of right now, like opening more medical schools. That takes a lot of action and political will to do, right? It's not the only one, it's just the one I can think of right now.
But it's a great one.
Well, thinking about medical schools.
There we go.
Ochsner Health just announced yesterday that we entered into a partnership with Xavier to create the fifth HBCU medical school. And so that's a big deal. And so we're doing our part to help with that. And they will be trained differently. They will be trained differently.
I want to be faculty.
And so, but beyond that, one of the things that I can't leave without saying is we have to vote. Because all the things that we've been talking about today is at risk. And so a call to action is you all need to vote, and you need to tell all your friends to vote, and you need to influence your organization to help people to understand how important this election is. So that's a call to action, because all of it, DE&I is at risk if we do not do that. The third thing is, I hope that this discussion has stimulated all of you to create your own personal action plan and strategy about how, if you're, I'm sure most of you are already involved, and if you are, get a friend to be involved and ask them, are you mentoring? Are you sponsoring? Are you participating? And if the answer is no, drag them along. So those are my 3 things.
Great. Those are all wonderful things. So I'll jump in here as well. So I think also continuing to allow students and young people, or even people who are in the field, because people are experiencing burnout too. We're also losing, to practitioners of color or diverse practitioners. And so all of the possibilities that each of these roles or that are available within the healthcare workforce. Sometimes we think very, narrowly, doctor must show up this way, pharmacist must be here or this, but like as healthcare and the way we treat patients is evolving, each of those roles are evolving as well. And so people don't, or those, each role doesn't always show up in the same way. So continuing to provide those opportunities. And with that, I would just say thank you to all of our panelists. Appreciated the conversation and hope that it'll continue beyond this room and beyond this session. Thank you so much. Questions that folks want to ask, we can do a little Q&A.
Q&A.
Yeah.
Oh, there's a question.
All right. Hi, my name is Christopher Smith. I'm a scientist and a researcher as well. So this question is for Dr. Cunningham.
Okay.
I was just wondering, so I've looked into like genetic testing before, and as a Black person, I have my own personal reservations about it. And so I was wondering, when you go into the communities and you want to reach out to them and help increase their comfort with doing those types of techniques, what kind of techniques do you use to help make them feel more comfortable with that?
Well, the first technique is honesty. I'll kind of honestly explain what it is, right? And I know everybody has their own perceptions of genetic testing and what it's involved in. It's sort of this boogeyman for some people, but as someone who actually does sequencing, right? And I do this a lot. I do this as part of research itself. If I sequenced everyone in this room, right? It's just a collection of A, T, C's, and G's. I don't know anything else about you, and I can't really hurt you with that information. There's very few ways I can hurt you with it, as opposed to the benefit that's potentially, if I find a mutation, that you have a mutation that is actually life-threatening, that can really help you. So when I balance the risk-reward or the benefit versus potential hurt, the benefit always outweighs. So that's what I would say to folks. And then, again, if you honestly have reservations, it's not something you got to do, right? Just like you don't, have to go and get checked up about anything. But I guess as someone who does so much of the research, and I look at how fast the research is moving and how much, like, every week we're discovering new things that are going to be helpful to our communities, I see so much more the benefit than the potential downfall. And yeah, again, I would say I lead with that honesty. I mean, we don't know everything yet. That's the whole point. It's a big data exercise. But what I will say to this, particularly my African-American community members, if our data is not present, we will not benefit. So use the BRCA1 story I told you at the beginning. That's real. And there's prostate cancer and other cancers that disproportionately affect our community. We need to understand what those mutations are that we harbor and look at them early so we can get into treatment earlier. Because all my clinician friends will tell you, the earlier you diagnose something, generally the better the outcome, right?
And we have a question on this side of the room.
Hi, I'm Tara Robinson, the co-founder of Black Heart Association. We talked a lot about, I heard you guys talk a lot about education and mentoring. Previously, as a school counselor, how do you think we attack the issue that we run into in Title I districts where there is no STEM. It's a fight to get STEM into our systems early. So what would you suggest? I love the Bridge program, so I can't wait to talk to you later on about that. I think that's awesome. But what would you suggest? Do you think it's important to have those conversations or invite those key stakeholders into the room?
It's absolutely critical. In the same way that our schools are being depleted of arts programs, of history programs, I think more than anything, the policy advocacy that needs to be made to get the funding in place, to get the support that you need to establish those programs, they have to be in the room. At the same time, there may be, depending on locally where we're talking about, there may be nonprofit organizations where you have mentors that can help support the additional education that unfortunately isn't being delivered in schools. It's a sad state of affairs, but sometimes those partnerships that we described can be equally as beneficial. Girls Who Code and many of those organizations that are out there are available for a lot of that support.
We have a question over here.
Yeah, thank you for a great panel. My name is Kamara Jones, and I'm a communications professional, and narrative, as we know, is powerful. The BRCA1 gene narrative, for example. When we have these conversations, though, I don't think we talk enough about what the lack of diversity actually looks like from a narrative perspective in the doctor's office. I'm gonna just tell y'all one story. And I'm gonna see if y'all have stories of your own that may be helpful. But I was at HHS. That was my former employer. We were hosting a Black Health Summit, and a Black woman advocate, researcher came up to me, and she talked about the criminalization of Black folks when they seek care. And I'm thinking she's talking about like drug use and all of that. She proceeds to tell me a story of a Black couple who had lost their newborn. The dad gets emotional, and because the hospital is not used to Black men getting emotional, they call the police. There's a story in the New York Times about a woman getting a sonogram, Black woman. The person doing the sonogram sees her baby wiggling and says, "Look at the little hoodlum." So what stories do y'all have? Because we talk about models and metrics and competencies, but the stories, I think, is what we really need to really tell to really drive the point home.
You know, I think that's really, really important. And I think we have to create an ecosystem where those patients who experience that, they have a place to go. And they can go anonymously, because sometimes fear of, well, if I do this, my doctor won't take care of me. And so patients have rights. And every organization that's accredited, they have to inform the patient of their rights. And so in those scenarios, the patient have a right to be treated with respect. And I think both of those situations is disrespectful. They can go to Joint Commission, they can go to CMS, they can go to and complain personally, anonymously. Every organization has a complaint process because they're required to do so. And you have to go into it knowing your rights and knowing how to exercise your rights. That's one thing. And then I think as providers, we need to be scoping out, trying to find out what's happening. So in our organization, we round so that we want to know about the experiences before you leave so that we can do something about it. So I think you're right in your assessment. Hopefully those are small in numbers, but it's powerful in what it's doing to our community when you're saying we're trying to establish trust.
Thank you. We have one last question.
Hello, thank you so much for this panel. My name is Witza Saeed. I'm a federal employee. I work for HRSA, and so I work with graduate medical education programs embedded in community-based settings. So I feel one thing that we haven't necessarily talked about is sort of graduate medical education and how that could assist. So as a pediatrician, I feel that primary care is very important, particularly in the community-based settings in underserved areas. And so when you think about somebody as myself interested in medicine, initially interested in working with underserved communities like those who supported me to get to where I am, along the way during your journey of training, you lose that because that's not necessarily what you see. Particularly residency, we're training specialists and hospitalists. And so for programs like Teaching Health Center GME that sort of embeds it within the community, I think that's great. But just across the board, we don't really have enough training sites or training dollars really to ensure that we have the primary care workforce that we need. So any thoughts that you guys have on how we could help expand that and help sort of sustain that for what we need in the future?
That's exactly the point I was describing around exposure throughout the pipeline. So I completely agree with you as far as GME. My first job out of residency was at Cook County Jail in Chicago. I treated, the justice involved, good Lord. They were not all criminals, but they were in there. Justice involved patients of Cook County Jail. And that was totally through community-based rotations I did during my residency. So part of this is where I'm really advocating for students who are looking to match. You need to choose those programs that are going to give you those opportunities. I never would have thought to go into the correctional system without that sort of exposure. And I loved it. And I still think that was the most pivotal patient opportunity that I've had, even above and beyond the VA. I firmly believe in teaching health centers, however, and I used to be faculty at one in Chicago, and I do think we need to, from a policy standpoint, put more funding behind those. I think it's a travesty that we have such inpatient-focused training as far as medical education when the majority of care is not inpatient-based. We need to be training in community settings, all levels of staff, but particularly GME, like you're saying. I think there's opportunity there. We need to be putting pressure on program directors to create more of them, though, because I think that the inertia that comes along with how they run their programs keeps it very inpatient and health system focused as opposed to community based. It's a great point.
Thank you. Well, thanks everyone again for participating, and thanks everyone for joining us.
All right. Hello, hello, hello. This looks great. It looks like excellence. It looks like everything I ever wanted to see in my life. Is what my grandfather dreamed of. But he would like it better if everybody sat down. It'd look a whole lot better if everybody grabbed their seat. If it's not your birthday today, please sit down. If it's not your birthday today, Junior, sit down. Chris Cox, you can take a seat as well. We're just calling people out right now. Matt McMurray, you're working, but let's get everybody together. All right. I think we're pretty good. So I am not the MC tonight. I would never do that. I don't want that role. But if you're my best friend, you get called on at not necessarily the last minute, but you get called on to sort of help and assist, much like I call on Courtney Lang to just kind of get stuff done. All that. I call on this guy, Joe Briggs. And so my best friend, Joe Briggs, lead us.
All right. Very thankful for Brandon Garrett for giving me at least 24 hours before calling this time. As you may recall from last year, he called me in less than 24 hours to be the MC of this event, and we still had a great time. So now we're going to have an even better time tonight. Hello, everybody. How y'all doing tonight? Now, wait a second. I am the son of a Baptist preacher who became a bishop and ran a church for 30 years. So I'm going to do that one more time, and hopefully we'll get it right. Good evening, everybody. Good evening. There you go. Let's feel like we are in fellowship tonight. As I prepare the stage for our first person to come up, we will be joined by Bishop Carter, who will give us an invocation. Bishop Carter, if you could join me on the stage to give that invocation so that we can get this party going. I see people looking at those salads on their table. They want to get to them as quickly as possible. Bishop Carter?
Absolutely. If we can quiet our spirits. Oh God, what a blessing. We thank you for the National Minority Equality Forum. We thank you for the leadership of Gary Puckering, his team of leaders and workers. We again are renewed and revived to continue the fight with greater passion and zeal. Bless our gathering this evening. Bless the food and bless the fellowship. We pray. Amen.
Amen. We are going to do our best to keep this program on track tonight and on time. I'm saying that before I start calling people up to give remarks. So I'll say it again. We're going to do our best to keep this on track and on time. First up on the schedule tonight to give remarks are two people who I'm sure you're all interested in hearing from. One, a person that's near and dear to my heart, a person whose birthday party I have the pleasure of DJing every year, which is another job that I have in this town. When I'm not emceeing for my best friend, I DJ for my favorite congressman, Dr. Kelly. We're going to call Dr. Kelly to the stage so that she can give her remarks. She will be followed by Dr. Puckering.
Thank you to my favorite DJ. Good evening, everyone. I hope you all have enjoyed this year's summit. It has been so wonderful engaging with policy and industry leaders from so many parts of the healthcare industry. Throughout the sessions, we have seen common themes like building trust among communities of color, diversifying clinical trials, and decreasing disparities, including something I am deeply passionate about, and you guys know, addressing the crisis of maternal mortality among Black women. We have made so much progress, but there's still so much left to do. I'm honored to recognize some of the people doing this critical work. This year's 40 Under 40 are clinicians, patient advocates, researchers, and policymakers. NMQF chooses these leaders because of their work to build sustainable, healthy communities and make healthcare accessible to all. And I'll give a shout out to my Chief of Staff, Matt McMurray, because he helps choose them too. So thank you, Matt. While I'm doing the work in Congress, they are making a difference on the ground. Their work embodies this year's theme, We Have the Data, Now What? A look back at over 25 years. The National Minority Quality Forum and its partners have been talking about health disparities long before the large institutions and the data caught up. But now that institutions in politics and medicine are paying attention, we have the responsibility to step up as leaders. The people in this room tonight will ensure that equity is at the center of new innovations in patient care. I always say it sounds cliche, but representation really does matter. We need more people of color in the healthcare workforce pipeline, in the rooms where the decisions are made, and in the chambers where laws are passed. Our work now will make sure that we don't need to wait another decade or another century for disparities to be taken seriously. We have the opportunity to push for change right now. Emerging technologies like AI, telehealth, and remote monitoring are changing the healthcare landscape more rapidly than ever. We can build equitable systems from the ground up instead of making corrections later. I'm doing all I can in Congress to make sure that our healthcare workforce and training reflects the realities of our need, but I can't do it alone. I need all of you to make your voices heard and do your part in your communities, your workplaces, and in the offices of your elected officials. As I said earlier, many of the things we've been able to do in my office is because you guys come and talk to us and give us your opinions and tweak what we might think about doing, tell us yes or no. So we depend very much on you. As the chair of the CBC Health Brain Trust, I've been so thrilled to work with NMQF and leaders like Dr. Puckrin for so many years. I know our work isn't done yet, and I look forward to our future work together. Thank you guys so much for being here. We really appreciate it. Take care.
Why? Because the space that they're talking about is not a livable space. Gun violence, absence of abortion, don't want you to be vaccinated, doesn't want to give you health care, want to round up millions of people and export them. I mean, if you just took the list, I think of it as Pottersville. Who the hell lives in that space? That's dark as hell. I'm sorry, you know me, I try to be on both sides of the aisle. I got a lot of friends on both sides of the aisle, but I tell my friends on that side of the aisle, I can't live there. I can't live there with you. My community can't live there with you. And so you need to get up off the couch. You need to get your family, your neighbors, those low propensity voters, whatever, because the future of our country is now on the ballot. So anyway, I'm going to stop here. I told you I talked too doggone long, and I'm sorry about that. But I think this is our moment. I think this is our moment. We can see the future. We know exactly what it looks like, and we can create that together. And so I'm asking my industry partners to go back to their shareholder value folks and say, hey, we can make a lot of money keeping people alive. We could do that. It's not a contradiction, right? So anyway, I promise to shut up. I'm going to do that right now. Thank you.
I think they deserve another round of applause. Not only because they are the reason that we're here tonight, but because they've been in the fight for the people that are in this room and the people who are not in this room but would be in this room because of their efforts. Another round of applause is deserved. And I'll stop you before you start just to say that we also have two other members of Congress here with us that I know of, Congresswoman Lee, Congresswoman Sewell. We appreciate you being here. We also, I believe, have Congressman Gabe Omo in the room. How about we give them all a round of applause because they have been fighting for us for a very long time. And there are a couple other people that I think we need to acknowledge before we move to the next thing on this schedule tonight. The staff at NMQF. Why don't we give them a round of applause for the 3 days that they've given us? Specifically, Ashley Hill, thank you for the coordination of this event. And the last thing before we go to the dinner portion of this program, Ebony, I know you looked at me when Brandon said I was his best friend. I'll acknowledge that you are also the best friend in superior position than me. Next thing on the schedule is dinner. You won't hear from me again until after dinner is served. Thank you very much, and we'll return to the music.